seniors, my teachers, and learned audience. Welcome to this national webinar of SOPSI. And for the first time, it's being organized by the Bengal chapter. This is my privilege that I'm starting the introductory comments on behalf of the Bengal chapter of the SOPSI. To start with everything, may I invite the Secretary of SOPSI, Dr. Haro P. Pattanayak, to give his introductory remarks, and invite the guests of today to give their address and messages to the entire audience. Now, Dr. Haro Pattanayak was the Vice President of FOXI in the year 2009. He was President Indian Menopause Society in the year 2015. Vice President Indian Menopause Society 2012, Secretary General Indian Menopause Society 2010, and Founder Secretary of Indian Menopause Society Odisha chapter. He happened to be the Governing Council member of ICOG from 2011 to 2014, National Corresponding Editor of FOXI Journal 2012 to 2015, Chairperson Geriatric Gynecology Committee FOXI 2004 to 2008, President Association of Obstetrics and Gynecologists of Odisha 2015-16, ex-Special Secretary Health and Family Welfare Government of Odisha, ex-Director Health Services and Director Public Health Odisha. So it's over to Dr. Haro Pattanayak to start your part.
Haroda, unmute yourself.
Good evening, everybody. Namaskar to all my seniors, all my respected dignitaries present today. Thank you, Samuel, for giving me this opportunity to speak to the august faculty present over here and large number of delegates who are connected today. Today is the birth of SOPSI Bengal chapter, and all the stalwarts of SOPSI are present today with the Lions of Bengal, who are internationally acclaimed, not only the national arena and not only state arena, but international platform. I salute to all of you today. And as you all know, that we have our patron, Professor Rustam P. Sonawala. He is the patron of SOPSI. First of all, I will invite him with a brief introduction of Dr. Sonawala to this meeting to give his blessings to SOPSI webinar today. Professor Sonawala is Padma Shri, rather I will tell that Padma Shri R.P. Sonawala is a towering personality, a great visionary and a great surgeon. And he was one of the 8 in the world to be awarded one Grafenberg Medal for original work in uterine contraception by University of Kiel, Germany. And in the year 1991, way back, he was awarded Padma Shri, one of the great civilian awards given to doctors today. He is honored by Giant International Award in September 20, and Rashtriya Shamman in 2002, and Lobster Foundation USA Award in January 2003. And he is the recipient of 42nd Dhanantari Award, and a special achievement is designed as Sonawala intrauterine contraceptive device in 1963, and several other gynecological instruments and surgical technique, especially for safe termination of pregnancy. Professor Sonawala was the president of FOXI, and even today, at this age, he is the most sought after surgeons in Bombay. I request Professor Sonawala, the patron of Societies of Vaginal Surgeon of India, to bless the occasion and to start the proceeding. Professor Sonawala, please.
Yeah, thank you. Thank you to everyone. First of all, I would like to thank the organizers for giving me this opportunity to be a part of this learned gathering that we are having. A few things which I would like to say. After 1960, the whole approach to medical practice completely changed. Ultrasound came in, the visualization, CT scan, MRI, then the surgeries which could be done far away, and yet one can be benefited by it. And all these new techniques have come. But in the long run, for a country like India, a simple technique of a vaginal approach for a female patient having any malignant problem is still the gold standard that we have to follow. I would also like to congratulate Dr. Jha, because amongst us, if you would just count on the pamphlet, we are 18 gents and she's the only lady. We 18 gents are discussing a lady's problem and she is the only representative from the lady side, which I think is not very right. More ladies, and especially in India, now we have so many of the ladies who are outstanding, and we should promote them also as much as we can. Now, malignancy only is going to be on the increase because our life expectancy is going up. At one time it was 60 years, 70 years, 80 years, and now it is calculated to be around between 85 and 90. So as our life expectancy goes up, the incidence of malignancy is going to go up. And therefore, the first lesson that one has to know to control malignancy, early detection, is the principle on which one should work. So prevention by whatever knowledge we have, but as soon as some unfortunate lady is struck with the problem, early detection and early treatment can be 100% cure. And I would just like to say that in India, we have got tremendous talent, tremendous brain power. We have to utilize it by this sort of seminars and good articles, and our good record keeping, which we definitely lag compared to the Western and other countries. I wish this conference all success and congratulations for taking so much pain to train or teach so many doctors at one shot. These webinars are an extremely well controlled tool by which we can spread the knowledge from north, south, east, west of India. And I wish the Congress or this meeting all success. Thank you. Thank you.
Thank you, sir, for those kind words and your blessings to SOPSI and today's webinar, Malignancy in Vaginal Surgery, or Vaginal Surgery in Malignancy. Next in order is our President of SOPSI, Professor Siris Seth. We all know sir is one of the three surgeons, gynecologists from India to hold the prestigious post of President FIGO. And he has the unique specialization in gynec vaginal surgery, particularly vaginal hysterectomy. And we all know that he has shown the world after Dr. Purandare and Dr. Sonawala. Dr. Siris Seth has the largest contribution to the world so far as vaginal surgery is concerned. He is both past president of FOXI and FIGO, and today he is the president of Society of Vaginal Surgeons of India. He has many techniques. He has attended many conferences, workshops, and we all know. And in our own AI Shioji, the vaginal surgery workshop is named after Professor Sirish Seth. And it is told that Dr. Sirish Seth vaginal surgery workshop. Professor Seth is kind enough to grace the occasion again, and I request him to bless the webinar and bless Sapsi again with his kind words. Professor Seth, please, sir. Professor Sirish Seth.
Can you hear?
Yes, sir. We are
Okay,
here.
fine.
with you.
Yeah.
Namaskar,
Thank you.
sir.
Thank you, Dr. Patnaik, for your
Yes.
very kind words. It's indeed a pleasure to be part of this program and listen to whatever you said. But it's, I think, as a professional person, it's duty to do something. We always say we are practicing medicine where an ounce of prevention is better than a pound of cure. And we are in a country where the population is so large. In other words, except China, nobody can have more uteruses than India.
Yes, sir.
And you find, if you take America or England or some of the advanced European country, the pap smear is routine in 95 to 98%. And I can say with little pain that in our routine, 95% plus do not have pap smear on a regular basis. These are the national statistics, as you can say. And therefore, I compliment for this program where I am sure one will look into. And after all, if we take a physiology, if we take nature, why go to abdomen so long you can do from the gynec area? Gynec vagina is only gynecologist area. No surgeon, no physician, no other multiple branches can ever claim, whereas we can proudly say that that is the area from where only a gynecologist can practice. And if it is possible, and so in the best interest of the patient's better being, why not approach vaginally the things which can be scientifically done without harming the patient? It's a pleasure to say these few words. And of course, Mahapatra, Patnaik, they all are very, very dear colleagues. And Dr. Sunala, and of course, we live in Bombay, and everybody has love for each other. And therefore, I thank you for inviting and to be part of this program. Thank you.
Thank you, sir. Thank you so much for gracing the occasion as President Sapsi. Next in order, I invite the National Convener, Professor P.C. Mahapatra, my guru, my mentor, and my guide.
Professor B.N. Chakravarti. B.N. Chakravarti.
No, sir, as a protocol, you are the National Convener of SAPSI, and you are to address after Professor Seth. And we all know that sir was ex-professor and head Department of Obstetrics and Gynecology in SC Medical College, Cuttack. And he was the past president of FOXI in 2011. He was the past vice president of FOXI in 2004. He was the chairperson of Medical Education Committee for 5 years from 2002 to 2008. He has been felicitated by Genius Dr. Mahapatra by Rairkwala OBGYN Society. He has been felicitated by Siridi Ratna, Siridi Sanman, and Best Doctor Award and Kuntala Kumari Sabat Award. And I always look upon him for all his techniques, and the whole country likes him for his executive speech, eloquent speech, and scientific comments and excellent surgery. I welcome sir to grace the occasion as our guest, and bless this webinar with your address. Sir, please.
Thank you, Hara, for overestimating me a little. Good evening to everybody. And today, all the galaxy of stars are there. And it's today a memorable day for me because every month we are doing this SOPSI monthly webinar. And today is the turn of West Bengal. I'm very fortunate and I'm delighted that after the SOPSI being formed, the state chapters are very enthusiastic. And I remember the day when SOPSI in 2018, when Professor Sukanta Misra voluntarily told that, yes, I am offering this responsibility of taking charge of West Bengal. And I was delighted that spontaneously people have come forward for this SOPSI chapter opening. And thank you very much for whole of the team of SOPSI West Bengal for initiating this event. And by now we have done last couple of months in different states. We have done the monthly webinar on a particular focused topic. And today is one of the very, very memorable things for me because my teachers, I have learned vaginal surgery from Professor Sirish Seth and Professor Sonawala. Both are here. I have learned endoscopic surgery from Dr. P. Das Mahapatra, who is here. And I am being stimulated in dedicating myself to infertility work by the great teacher and teachers of teachers, Professor B.N. Chakravarti, who is here. So therefore, I believe that today all my teachers are there and this is a wonderful event and a memorable event on my part. And I congratulate the West Bengal SOPSI for emotionally blackmailing all these stalwarts and bringing in this to forum. The credit is to you. Nobody could do this job for that. Sukant and Shamal are really veteran in kidnapping all these people. And therefore, I'm very happy that today in this webinar, they are there and given their address for that. Please bless us, everybody. And it is your brain, your dream, which we are just carrying out the program for that. And now we feel that we are satisfied that we have been able to do the program and a long way to go in the future for that. Regarding the topic, I will speak one thing, that today they have taken a very, very special topic on malignancy. People say that malignancy is only part where vaginal route is not preferred for that. And they have taken a challenge for that. Because West Bengal is a place where veteran surgeons like Professor Subodh Mitra has started the vaginal radical procedure after Sauta and a modified thing, particularly for vaginal radical surgery, along with bilateral lymphadenectomy by giving an incision over it, and which now has been really complemented by laparoscopic removal after vaginal hysterectomy. People now in next new generations should go more and more for this in a case of. There are two cancers where vaginal approach can be done. One is an endometrial cancer, carcinoma, and therefore second is a carcinoma cervix. Now the carcinoma cervix, the main advantage of vaginal route is the demarcation of the lower limit of the vagina, which can be better defined vaginally than abdominally. That's clearly so. And a good technique has been developed by the Bengal surgical mind, and they are pioneer in this particular technique. And great salute to Professor Subodh Mitra on this day. I remember my teacher who has taught me gynecology, Professor Ashish Dey, always tells in the ward rounds that I am fortunate to become the direct disciple of Professor Subodh Mitra. And he always tells that he has the technique and all that, how inspiring it is for them. Now, I feel that the vaginal route is giving more momentum when genital malignancy has come up, particularly in a situation where we're in a declining phase in prevalence of carcinoma cervix and an increasing trend of endometrial malignancy. Now, this is a case where vaginal approach should be the route for that. And nowadays, we find more and more of endometrial carcinoma. And early endometrial carcinoma, the world literatures and all evidences shows that there is no reason for a lymphadenectomy. Simple hysterectomy can be enough for that. And bilateral salpingo for it. And when there is no contraindication, people are expert in removing the ovary People who say that, yes, when removing the ovary needs a laparoscopic removal, they are wrong. We can remove the ovary and uterus in a case of stage 1A endometrial malignancy, which is very common. And nowadays we find more and more such cases, and that too in risky cases like obese, like hypertensive. I think these are the cases where vaginal takes an advantage out of it also. I hope that during the whole session, all things will be clarified and we can learn more about the more and more of vaginal route by genital malignancy. I remember a talk given by Professor Siri said the topic caption was more and more by vaginal route. I was surprised, more and more by vaginal. It's not hysterectomy, it's everything can be done. And even endometrial malignancy, cervical malignancy cannot be a restriction for vaginal route. And I hope that the expansion of the route of delivery of the uterus and indications are expanding. The spectrum is expanding on the vaginal. Today, the Bengal SOPSI chapter will really do a good job in telling, then propagating the idea that it's not contraindicated, rather is the indicated. Yesterday's contraindications are today's indications, and that they will emphasize. I again congratulate all of you for this congregation in this beautiful, I think, 14th Valentine Day, collaborating with the genital malignancy. People are celebrating Valentine, and we are celebrating our SOPSI forum dealing with the exceptional circumstances on malignancy. Thank you very much, Shamal and Shukant and Tulika, for giving me this opportunity. And salute to Vasudev Da and Biman Chakrabarti and all the great to Dr. Mandal and everybody gathered together and a galaxy of stars present here. Thank you.
Thank you, sir, for your kind words and words of wisdom. Samuel, I have done I now hand it over back to you to start the academic proceeding. And I welcome our President Bengal Chapter, Professor Sukanta Misra, and the Secretary Bengal Chapter, Dr. Samuel Seth, to start the scientific proceeding with the opening remarks by Professor Sukanta Misra. Over to you, Tulika. Thank you, everybody.
Thank you, Dr. Pattanayak. What a pleasure indeed it is for all of us to be here this evening amid so many stalwarts, people who we look up to, people from whom we have been learning all through our lives. It's indeed an honor and pleasure to be here. To further the proceedings for the evening, I would like to invite the founder president of the Bengal chapter of SOPSI, Professor Shukanto Mishra, to say his welcome address and president's address. And we move on to the next part of the program, and that is Dr. Mishra's address. Shukanto, the stage is yours.
Respected teachers, dignitaries, colleagues, and my friends, I have become a little emotional today. Good evening to all of you. On behalf of the Bengal chapter of the Society of Vaginal Surgeons of India, as a founder president of this particular chapter, it's a great honor and privilege for me to extend my sincere and heartiest welcome to you all on the occasion of the first webinar organized by the Bengal chapter of SOPSI, that is Society of Vaginal Surgeons of India, what we call in short term SOPSI, on a very interesting topic of vaginal surgery in malignancy, and that is being reiterated from time to time. Many luminaries, as you can see, in this field of vaginal surgery are present here today on the occasion of Valentine's Day's evening, discussing on a vagina, and it's a very proud and special moment for all of us. Dr. Shunawala said, no one can imagine what's your age. Despite being an octogenarian, your activity, awareness, agility, and the responses are worth mentioning. It's exemplary. Your keen interest and extreme degree of skill in vaginal surgery are just exemplary. And sir, your blessings are wealth for us. We look forward towards you so that we can proceed. And please, we will welcome you on behalf of the Bengal chapter with a lot of respect. Dr. Siri said,
Thank you. Thank you very much, sir.
Sir, I called you and you responded immediately that yes, I'll be there in time. So Dr. Siris said, sir, past president of FIGO, he's the person responsible not only for resurrection, but also for establishing firmly the vaginal route of hysterectomy, which I would rather say the signature operation for any gynecologist across the entire globe. Again, when I called him, sir, you have to be there to offer your blessings because we need that. He immediately responded by saying, Dr. Sukant, don't worry, I'll be there. I'll be sending you the book. Give me your address, the advances in the vaginal surgery. Immediately send me the address. He noted down it in diary. And he is there with us. Sir, your blessings are our inspiration, strength. With a lot of humility and respect, I welcome you, sir. Dr. P.C. Mahapatra, what can I say? He's a visionary. Who doesn't know him? Besides having a great organizing ability, he possesses a God-gifted skill in everything. As Dr. Patnaik said, eloquent in his speech, in all types of surgery as well. As the memory of the day of the year 2018 is still fresh in my mind. Dr. P.C. Mahapatra convened a meeting at Bhubaneswar with those across the India, those who are interested in vaginal surgeries, to form a society of vaginal surgeries of India, spearheaded by giants like Dr. Sonawala sir, Dr. Siris Seth sir. He has a dream and he's chasing the dream and he always catches the dream and he always rides over the lion. He prefers to do that. All of us were present there and witnessed and became a part of this journey. He deserves a salute for this unique endeavor. But I know despite his personal loss of a family member, he's still with us. Thank you, sir. We need you, the national convener of SOPSI. Recently, since last 25 years, maybe 30 years, with the introduction of SCOPy in the field of gynecology, the scope of vaginal surgery is gradually getting narrowed down. I understand it is rather unintentionally. But even in cases of pelvic organ prolapse and reconstruction of vagina, laparoscopy route was tried, considered, often ignoring the benefits of vaginal route. While I understand that laparoscopic route should ideally supplement the vaginal surgery, it actually pushed it in the corner. And vaginal surgery is gradually becoming a dying art, particularly to the newer generation of the gynecologists. This is a sorry state of affair. Not many workshops and discussions were there under any organized platform where skilled vaginal surgeons can share their skills, tips and tricks to the junior fellow so that the women for which we all belong to, they ultimately become the beneficiary. During COVID pandemic, when we all are locked down to our residence, Dr. H. Patnaik, as you know, is a good friend of mine, the honorary secretary of SOPSI, the workaholic. He came out with a striking idea of organizing monthly webinar on a Sunday. Each state chapter was given responsibility of organizing such webinar for the benefit of the present and future generation of the vaginal surgeons. It instantly became such popular that the participation became rather quite astonishing. I welcome you, Dr. Patnaik, sir. The Bengal chapter was entrusted by him with the topic of vaginal surgery in malignancy. For a moment, I was taken aback. Then quickly I realized that probably this is an opportunity. And in this platform, we would rather showcase the operation of our teacher of teachers, Dr. Subodh Mitra. And as a founder president of the Bengal chapter of SOPSI, I would like to dedicate this webinar in the name of the nation's pride, Dr. Subodh Mitra, teacher of teachers, a great surgeon of international repute, who devised an operation for CSRDs. It involves bilateral extraperitoneal lymphadenectomy with extraperitoneal ligation of the ovarian vessels, uterine vessels, sound ligament, and along with vaginal radical hysterectomy. Sir, Professor B.N. Chakraborty, sir, he's our teacher. He doesn't need any introduction, although he's primarily known for his dedication in the management of infertility.
Many will be surprised to know that in the early part of his career, he was involved in popularizing Mitra's operation, along with my teacher, Professor N. Roy Chaudhary, who incidentally was also a close relative of Dr. Subodh Mitra. Professor B.N. Chakraborty had also keen interest in reconstructive surgery of vagina and in cases of Mullerian anomaly also. And he had also given a classification of Mullerian anomaly. Many people, they know it. While managing such cases, on a personal note, I can say I used to rush to him to have some tips. Thank you, sir, and I welcome you, sir. I'd also like to Professor Biman Chakraborty. I am one of his direct students. He is known for his great academic keenness. He's a great academician, and he attends all the conferences. You go there and you'll find him. He's always there. He's an innovative, skilled surgeon with a keen interest in gynecological malignancy. In fact, after his retirement, he is still actively attached with a cancer hospital. Sir, as one of your direct students, it is a privilege for me to welcome you in this webinar. I would also like to welcome Professor Partha Kumar Bhattacharya. Besides being a tremendously good human being, he is well known for his special skill in vaginal and cancer surgeries. I only know that he was a brilliant teacher and many of his followers are doing excellent job in India and abroad. It's a privilege and honor for me, sir, to welcome you in this webinar. I would like to welcome also Dr. P. Das Mahapatra, sir, a solo institution by himself, a man of indomitable spirit, with equal degree of proficiency and skill in both endoscopic and vaginal surgery, in addition to organizing ability. I feel really honored to welcome you, sir, in this webinar. I feel privileged to welcome the great surgeons, our seniors, our mentors, our dear and near ones, who always guided us in times of need, Dr. Sudeep Chakraborty and Dr. Vasudev Mukherjee, sir. I feel happy to welcome two vaginal surgeons from Bengal, Dr. Pradeep Kumar Mitra and Dr. Ashok Tudani, who are also members of SOPSI, who had keen interest in vaginal surgeries and are also an integral part in this journey of SOPSI. While considering vaginal surgery in malignancy cases, we have considered that we should take account of only CS cervix and vulvectomy this time, not CA endometrium, of course, and of course, Mitra's operation. And we are fortunate to have with us the two torch bearers, Dr. N.R. Mandal and Dr. K.D. Boxi. Because this webinar is dedicated to Dr. Subodh Mitra, they are the automatic choice. They are the most suitable ones to demonstrate this operation in front of this national gathering. Sir, I feel honored to welcome you both to show your art and skill in this surgery. I'd also like to welcome our dear friend, Dr. Joydeep Bhomik, head of the Department of the Gynae Onco Tata Medical Center, for video demonstration of radical vulvectomy. You will be amazed to see his skill in this field, and also my friend, Professor S.K. Giri, a renowned gynecological oncologist from Bhubaneswar, Cuttack, and the entire Odisha. He was the first chairperson of the oncology committee of FOGSI. He came here when I was president of BOGSI, BOGS, to deliver an oration on Dr. Subodh Mitra oration of Bengal of the Gynecological Society. And he will be demonstrating his skill in reconstructive surgery of disfigured vulva following radical vulvectomy. And I'll be failing in my duty if I do not welcome all the delegates across the country, and some of them are also international delegates. With my personal references, they are also joining over here. Colleagues and friends, sir, your participation in this webinar will go a long way, will make this conference a success one. And I, on behalf of the Bengal chapter of SOPSI, take the entire blame if there is any flaws in organizing this webinar. And I can assure you in future programs, we'll try to rectify those. I pay my respectful pranam to my teachers, to the dignitaries, to the seniors, and in the love and best wishes on the occasion of this lovely Valentine's Day, to all of you, I request you to enjoy the webinar now. Long live SOPSI. Thank you very much. Namaskar.
Thank you, Shukantoda, for those wonderful words. Welcome you as the founder president of the Bengal chapter of SOPSI, and also for this wonderful program which you have planned along with Shamulda and conceived, and which we will enjoy over the next few hours. Vaginal surgery is indeed an art. and a field of expertise which is ours alone. By ours, I mean the gynecologists alone. We have entire, like sort of right over that. And those of us who love vaginal surgery, we know that completing a difficult vaginal surgery, especially in a malignancy case, gives a high actually. So let's move on with the academic sessions to enjoy some beautiful vaginal surgeries by some of the stalwarts in the field. And to start the first academic session, it is my privilege to call upon the chairpersons. The first person whom I want to call upon the virtual dais is none other than Professor Biman Kumar Chakraborty. Support team, would you please show the slides now? Just go back. Now go back. Sir really needs no introduction, especially in the field of gynecological oncology. And he was a postdoctoral fellow in Johns Hopkins University. He was a former professor in Medical College Hospital. He's the head of the Gynae Oncology Division in Saroj Gupta Cancer Center Research Institute, Thakurpukur. And he was also one of the past presidents of our society, that is the Bengal Obstetric and Gynecological Society. Welcome you, Dr. Biman Kumar Chakraborty, to this seminar. Namaskar. Next slide. Next slide, please. Next slide, please. I would now like to call upon the stage Dr. Basudev Mukherjee, consultant gynecologist in Kolkata, is very senior and respected gynecologist. He was also the past president of the Bengal Obs Gynae Society. He's the chairperson of the, he was the chairperson of the Public Awareness Committee, FOXY, in 2003-2007. He was also the past secretary of the Kolkata chapter of Indian Menopause Society. And his special interests are public awareness programs, menopause, endoscopic surgery, and is also a wonderful surgeon and a very respected member of the Bengal Society. And so welcome to you, Dr. Basudev Mukherjee.
Thank you.
Next slide. Next, on the next chairperson, I would like to invite to the stages Dr. Promothesh Das Mahapatro. He's the director of the Spectrum Clinic and Endoscopy Research Institute, Kolkata. He's an honorary consultant attached to Kothari Medical Center, Kolkata. He's the former chairman of the All India Coordinating Committee, RCOG, London. He's also been an examiner for his MRCOG and FRCS, Edinburgh. Founder Secretary General of the Endometriosis Society, India. He's been attached to several respected societies in the field of gynecology and otherwise. And the most interesting thing I noted was he's also the president of the Mountaineers Association, Krishnanagar, and he holds a private pilot license and is an aviator. So that's so interesting to know, Dr. Mahapatra. And so welcome, Dr. Promothesh Das Mahapatra, to this session. Welcome, sir. And now, last but not the least, we have Dr. Ashok Kumar Todani. He's a consultant at Laparoscopic Center and Sonography Clinic, Raniganj, West Bengal. He's the director of the clinic. He has several publications, awards, and recognition. And his special fields of interest are sonography, infertility, non-descent vaginal hysterectomy, and endoscopic surgery. He has delivered more than 118 lectures at various conferences, and he was the president of the Durgapur Obs and Gynae Society in 2015 and the secretary before that in 2013 and 14. We are indeed happy to have you here, Dr. Todani. So welcome all the chairpersons, and I would hand it over to you to start the proceedings of the next session. Vasudevda.
Good evening, everybody. At the outset, I would like to profoundly thank SOPSI and Bengal chapter giving me this opportunity to chair a wonderful session like this, and in presence of that galaxy of my teachers, colleagues, friends, and brothers. And it's my privilege to introduce the first speaker, Dr. Kalidas Bokshi. May I have the slide, please? Dr. Kalidas Mokshi has graduated from Calcutta National Medical College, the same as mine. He's senior to me by 2 years, past president of BOGS, president Indian Manpower Society, Bengal chapter, president ISAR, Bengal chapter, organizing chairperson INSCON 2019. And his special interest is oncosurgery. Who doesn't know him? He has done the practical demonstration in Foxy conference as well. The floor is yours, Kalidasa. Please go ahead.
Respected chairpersons and the dignitaries, at the very outset, I must thank our President, Dr. Sukanta Misro, and Secretary, Dr. Shamal Sheikh, and all the senior teachers of mine to give me the opportunity to display this famous operation, Dr. Subodh Mitro, the legacy which I am being still maintaining. I have learned it from my teachers. It is very well known to all the seniors, Dr. D.K. Roy, Dilip Kumar Roy, Dr. Ellen Bose, Dr. Loknath Bose, Dr. Panak Bina Dasgupta, Dr. D. Rai, and who else? Though I am not very fortunate to get training from Dr. Subodh Mitro, but I took the training from all these seniors who were the legendary seniors at that time who did this very famous operation. I am just maintaining the legacy of them and giving my pranam to them. I am just starting my video. To start with, I must be, I must describe the origin of this operation. In 1931, Dr. Subodh Mitro presented the result of treatment of different stages of cancer cervix by radiotherapy with 5 years follow-up at International Radiological Congress. At that time, surgical treatment of cancer cervix in the early stage is highly satisfactory and can overcome the complications of radiotherapy. 16 years later, that is in 1947, outcome of results of Schauter's operation was presented at London Royal Society of Medicine. It was highly accepted, but it was not without criticism. The reasons were draining of lymph nodes could not be removed, and outcome of this surgical procedure was debatable. With this back of mind, Dr. Subodh Mitro went to Vienna and started working under Professor Amre in the Department of Anatomy, where he attained the aptitude of pelvic anatomy and dissection of draining lymph nodes by extraperitoneal way on cadavers, and established his famous Mitro's operation by combining this operation with Schauter's vaginal hysterectomy in 1952. Now, regarding Mitro's operation, it has got two parts. One is extraperitoneal part and another is vaginal part. Extraperitoneal part is the important steps are dissection and removal of the pelvic nodes, external iliac group of nodes, internal iliac group of nodes, inguinal group, paraaortic group, sacral group, and other groups if necessary. Ligation of uterine and ovarian vessels. In vaginal part, as like Schauter, special advantage is massive removal of the parametrium from the lateral wall of the pelvis. Almost total vagina can be removed if required. And vaginal part, the advantage is what Dr. Rashmahapatra said, that the extent of vaginal involvement can be well assessed by the vaginal room. This is the one of the very great advantages of this. In 1952, Professor Subodh Mitra demonstrated this operation in Vienna at Sauter's clinic, and since then, this operation came to be known as Mitra's operation. This is the in nutshell the history of this Mitra's operation. This is the incision line, abdominal part, point at the junction of the middle two-third and lateral one-third of the spine umbilical line. Make a point 1 to 1.5 centimeter inches above the point A and point at the pubic tubercle. This, if we join by imaginary line, this incision can be given. It is the cutting the skin and subcutaneous tissue along the line of incision, followed by cutting the external abdominis muscle. And cutting the internal abdominis and transverse abdominis along the line of incision. This is how we separate the muscle from the extraperitoneally by just finger and blunt dissection. This is the bulk of the muscle of the internal abdominis and the transverse abdominis muscle. This we cut along the line of incision. After that, we identify the round ligament and we cut in between the clams. This is the round ligament we have cut it, and I am ligating the round ligaments. Cutting between the clams and ligation of the inferior epigastrium. This is very important because the advantage of identifying the inferior epigastric and cutting in between is that the chance of bleeding is much less, because due to traction sometimes it is damaged and injured and gives a very bad operating field. But if we do this to start with, the bleeding much less. We cut in between clams and then we ligate it. Then retraction of the peritoneal contents by assistant and identification of the ureter along the course of the incision. This part is also very important because here the assistant's help and traction is very much needed. Here we identify the ureteric course extraperitoneally by seeing the movement of the ureter, peristaltic movement of the ureter. We identify this is the ureter I am showing you, and soon it will exert its peristaltic movement. This is the peristaltic movement of the ureter, and we can identify the ureter very nicely. Here now, after that, we identify the big vessels like common iliac, external iliac, internal iliac, and try to identify the lymph nodes, whether it is big or small, whether it is superficial or not, we identify it. Here, for the demonstration only, how internal iliac is tied extraperitoneally, I am showing this part, though it is not a part of the Mitra's operation. This is the bifurcation of the common iliac, internal and external, and here this is the identification, and that is the internal iliac is being seen to pulsate in the pulsation, I am tying the internal. This is not the part of the Mitro's operation. We use the internal artery and the vein. Now, this part, we identify the obliterated
Anterior division of the
umbilical artery, and below that is the uterine. I am dissecting by a right angle forceps the uterine artery. This is the uterine artery and the vein. And this will be tied in between the clamps. This is the uterine artery along with the vein. By right angle forceps, we just dissect it and cut in between clamps. Here I shall identify the obturator nerves. This is the obturator white line. This is the obturator nerve. And in the obturator fossa, the obturator glands lining, and that will be taken out after lifting the obturator nerve. And this is the way to dissect the obturator gland from the obturator fossa, and we'll dissect from. This is the way we dissect the obturator, this flat big gland, that is the obturator gland. And we take out in bunch along with the external and internal iliac group of glands. That is the in block, I am removing. That is the way of removing N block of the whole pelvic lymph nodes. This is the block dissections of the pelvic glands. External, internal, and obturator. This part is also very important. We are identifying the course of the ureter. That white area is the ureter, white line is the ureter. And here we identify the ovarian vessels, and will separate it extraperitoneally. And the way of dissection to separate it from the peritoneum is by blunt ways of dissection. This is peanut dissection, and sometimes we do by fingers also. This is the, we'll identify it and we'll cut in between clamps and we'll tie the ovarian vessels. This advantage of tying the ovarian vessels and the uterine vessels from extraperitoneal route will get the benefit while we do the vaginal part of the surgery. This is the mampiniform plexus of the ovarian vessels, and each of the vein should be taken in between the fingers so that there should not be any bleeding. It is the way we dissect it. And this is the peritoneal fold, you see, and it is all done extraperitoneally. This is cut. This is identified, cut in between clamps, and it is ligated. Now the closure is in usual way, but one thing is very important. To prevent hernia, we will take a bite while we go down from the conjoint tendon, so that if we take the conjoint tendon in our stitch, then thereby we can prevent the herniation. At the bottom, we take the conjoint tendon while we close the abdomen. This is anatomical closure, but the one important point is we have to take a bite from the conjoint tendon to prevent hernia. This is the white line. I am taking the bite from this is the conjoint tendon, and while it going down, this is the conjoint tendon muscle with the conjoint tendon, and this is the conjoint tendon. And the rest is is nothing special. It is by usual way. This is the end block removal of the glands, external oblique, internal oblique, common iliac, obturator. This is the glands in the picture. Now the vaginal part, this is the second part of Mitro's operation, that is the vaginal root. All stalwarts of vaginal surgeons are here. I am very fortunate to present my presentation in front of them. This is the patient having the diagnosed cancer cervix, and this is called the extended episiotomy or Shukar's incision. This is very important. We just extend the incision of the episiotomy, and the idea of giving this Shukar incision to get the relaxation of the vagina.
More space.
Now, this part is very important, cuffing of the vagina, formation of the vaginal cuff. Here, the advantage is that we can clinically identify the extent of the growth, and thereby we decide from how much portion of the vagina to be removed. This gives incision in the vagina, anterior wall. This incision will be all around the vagina so that vaginal cuff may be made. We are just dissecting the vesicovaginal space bluntly, and of course some of the, due to traction, vagina is being, bladder has been retracted automatically. And this every nick is very important, and the assistants help to retract the bladder wall is another very important steps of this operation. This incision will be given all around the vagina, and paravaginal tissue will be dissected. Later on, we will show you. This back of the knife. That is another good way of dissection without injuring the many soft tissues. This incision will be all round. This cuffing of the vagina will be judged by the surgeon according to the extent of clinical assessment of the growth. By sharp scissors dissection, the vesicocervical and vesicovaginal spaces are being dissected, and with the help of the assistant who retracts the bladder automatically goes up. And forceps is very important. This is called mouse tooth forceps. This forceps was mainly rather invented by Professor Mitra. This advantage of this mouse tooth forceps is that vagina is very soft. It will not be torn away while we give the traction, because in this surgery, traction is a very important part. And this forceps has got multiple teeth, and that's why it is called mouse tooth forceps. This is the lateral dissection, and with every we are just separating the vagina, and also along the retraction of the bladder, ureter is also pulled up. This is the bladder line demarcated. Every nick of the scissors is very important, because every possibility of injuring the ureter over there. So this traction and retraction is very important. This ureter is being under lateral retractor. Ureter is being guarded by lateral retractor. And here we are very desperate, because we have already tied down uterine artery from above. So no question of bleeding also. No question of bleeding. We are very desperate here, because there is no chance of bleeding. Only problem is with the ureter. We must be very careful about it. As because it is a deep dissection, this is the part of the ureter you can see. Ureter cannot be shown very nicely, because cameraman was not very competent to focus inside. This is the uterine artery. You see that vessel, and we have already cut and ligated. So no question of bleeding from there. This is, we are retracting the we are opening the anterior pouch. This is the anterior fold of peritoneum. After opening it, this is the opening of the anterior pouch, and we will give a roller gauze pack so that abdominal contents will not come in the field. This is the opening of the posterior peritoneum also, pouch of Douglas. This is the fold, and posterior peritoneum is cut. That is the posterior peritoneum. Now, after opening it and giving pack, we are now delivering the uterus. This is the way we deliver the uterus, gradually. And we have got some special instrument which at that time not available, that is called cat's paw. And by cat's paw, we can pull out the uterus very nicely. And here I am mobilizing the ovaries, and ovaries will be delivered. Here is also, we are very courageous because we have tied the ovarian vessels on both sides. Only thing is that we have to give a sharp neck to the IP ligament so that it becomes easier to pull the ovary along with the vessels. This is the neck will give with this is the dissection of the peritoneal fold. This is the way. This is the peritoneal fold. We are just releasing it, and ovary will pull out the ovary. One-sided ovary has come out, and we are not very afraid of bleeding over here because we have already tied the vessel. Other sided ovary will be delivered. The technique of delivering the ovary sometimes requires the experience. In many ways we can take out. This is one way I shall show you by which we can take out the ovary. When ovary is rather slightly adherent, this is the way we just deliver it. And here also we will give a neck to the peritoneal fold so that the delivery of the ovary becomes easier. And here is also no question of bleeding from the IPL. We are just cutting the fold of the peritoneum so that delivery becomes easier. You see the ovary has come out. The next part is we will cut in between clamps the uterosacral ligament so that uterus will be absolutely free from attachments except McEnroe's. Posterior attachment by uterosacral is being cut. Sometimes it bleeds, sometimes we cauterize, sometimes we tie. It all depends on the surgeons and the amount of bleeding. Sometimes we pull it in to my finger so that I can identify the uterosacral and do it accordingly. This most important part is taking the McEnroe's from the lateral pelvic, almost from the lateral pelvic wall. We hook it by inserting our finger, and we give a traction so that the McEnroe's can be taken out from almost from the lateral pelvic wall. Sometimes we cut it in between clamps with ligature, and then we cut. It all depends how the surgeon is trained. It is. I am lighting over here because McIndore's are caught in McIndore's is caught in between the clams. So for safety, I am giving the stitches. So you see, by hooking and pulling, I am taking almost McIndore's from the lateral pelvic wall. The same will be repeated on the other side also. This is cutting and tying. This is one way of thinning the McIndore's so that it can be given very tightly and comfortably. One will be applied and the specimen will be taken out. One is applied and specimen is out. Risk of the surgery like vaginal hysterectomy, nothing very special. Only few bites and to prevent any the conventional way of repairing of the vagina, as we all know, it is nothing special over here. This is the means operation where to do radical hysterectomy, that is I have already said. Adequate removal of vagina, parametrium and minimum bleeding. Operation can be done by expert hand within 30 to 45 days. Post-operative complications, morbidity, mortality is much less. In selected cases, 5 years disease-free interval is about 85 to 90%. leading to much less operation time, which I have mentioned earlier, 30 to 45 minutes. Disadvantage, sex life is disturbed due to short vagina, and as the present concept, early detection of the cancer and late marriage, part of the sex life is very important. So in that case, tracheotherapy and radical tracheotherapy may be the ideal. In that case, hysterectomy operation, vaginal hysterectomy may be a problem so far as sex life is concerned due to short vagina. And if radiation is needed, the future of the vaginal, that is, a vaginal application will not be possible because vagina is very short. Thank you very much.
Excellent.
Thank you, Dr. Mukti, for your excellent demonstration of the methods operation. I know there will be a few questions, especially today's era, with the advent of laparoscopy, combined laparoscopy with radical removal from below is feasible. Of course, it is feasible. I remember Dr. Shri said once in Calcutta that advantage of laparoscopy is to facilitate or make the difficult vaginal operation easy. So that is always in my mind, and I do believe that. So not necessarily we have that tremendous pleasure nowadays doing total laparoscopic hysterectomy, but it doesn't matter. If we do the ligation of the vessels, sometimes lymphadenectomy and radical removal through vaginal passage, perhaps it's a thought. We'll come to the discussion later on. May I hand over to Professor Biman Chakraborty to introduce the next speaker for the next operating session. Thank you.
Dr. Biman Chakraborty, sir.
Dr. Chakraborty, sir. Sir, unmute yourself. So you, okay. স্যার শোনা যাচ্ছে না মনে হয় ভলিউম
স্যার জোরে বলুন আনমিউট করে দিন স্যার
স্যার ভলিউমটা মনে হয় কম আছে স্যার একটু ভলিউমটা বাড়াতে হবে
একটু কথা বলুন
Sir, we can't hear you.
Sir, are you there?
Sir, ল্যাপটপের ভলিউম কিংবা ইয়ারফোনের কানেকশনটা একটু দেখবেন somebody from the support staff please help
Yes sir. Yes sir, please speak. Yeah. Hello sir. Sir, please unmute yourself.
He is unmuted.
স্যার আপনি আনমিউট করুন ফার্স্টে বিমান স্যার আপনি ফার্স্টে আনমিউট করে না আমার মনে হয় আপনার হেডফোনটা কিছু ইয়ে হচ্ছে আপনি একবার হেডফোনটাকে আরেকবার কানেক্ট করুন স্যার আপনি একবার আনমিউট করুন আপনি মিউট দেখাচ্ছে এখনো
সাপোর্ট স্টাফদের আনমিউট করে দাও না
Yes sir, I unmute him.
হ্যাঁ সো
Okay.
Please speak sir.
There is problem with microphone.
Yes, I think he is having some problem with his microphone. Because previously sir was unmuted only.
ইন্টারনেটের কানেকশনও মনে হয় একটু গন্ডগোল আছে বিকজ স্যারের পিকচারটাও চলে গেল
I think Dr. Tulika, we are not able to hear Dr. Biman Chakraborty. Let another esteemed chairperson introduce Dr. Mandal so that he can speak later.
Yes, I think we can do it.
Yes.
Dr. Dash Mahapatra, would you please introduce the next speaker?
It's my pleasure to introduce Nidhu Ranjan Mandal, a very close friend of mine who comes to help me on and off on my cancer cases. As you know, he is a senior consultant and in charge of Department of Gynae Oncology, Saroj Gupta Cancer Center and Research Institute, and he is a practitioner in gynecology and obstetrics. He does obstetrics as well, as far as my knowledge goes, but he is a complete gynae onco surgeon, and I really have seen him operating many occasions. In fact, when we conducted in 2004 only vagina for 2 days, he demonstrated vaginal hysterectomy for CS cervix, if you remember, Nidhi. May I invite you to give your talk now, please?
Good evening, sir.
Good evening.
Hello.
Yes, sir. Continue, sir.
Yes, you are audible. Please continue.
Yes. Okay,
Please continue.
Good evening, sirs. It's my privilege and to have these occasions in front of my respected teachers and the stalwarts in this field of gynecology and obstetrics, not only in India but abroad. Now, initially, when Dr. Mishra phoned me to give this presentation, I agreed immediately. But after seeing the names of the stalwarts, I am a bit nervous. But now, after doing 2 trials, now I'm confident that I can my presentation will be all right. So now I'm giving my presentation to radical vaginal hysterectomy, that is Mitra's operation. In fact, my previous speaker, Dr. Bokshi, has already mentioned the history of these Mitra's operations, but I will not go in details. So we have already seen radical vaginal hysterectomy with extraperitoneal pelvic lymphadenectomy has been popularly known as Mitra's operation, and it is done in cases of carcinoma of the cervix in early stages, because stage 1B up to stage 2A. Now, it is named after Dr. Mitros, and he was the person behind establishing the Chittaranjan Cancer Hospital in Kolkata in 1950, and now still functioning as Chittaranjan National Cancer Institute.
Yes, sir. Sorry for interruption, but your slides are not visible.
Okay. Slideshow. I will give a slideshow.
Yes, sir.
Okay.
Share screen করতে হবে sir.
Now it is okay. Now it is okay.
No, sir.
Tulika, can you hear me?
Click on share screen button.
Share screen. PowerPoint share screen karo.
Tulika, can you hear me?
Yes, we can hear you now, sir.
আমি আপনার মোবাইলে এসেছি, ঠিক আছে?
স্যার ডক্টর দাস মহাপাত্র শুরু করে দিলেন, আপনি
হ্যাঁ ঠিক আছে, করো।
আপনি পরে বলবেন স্যার।
হ্যাঁ ঠিক আছে, ফাইন, দ্যাটস নো প্রবলেম।
Now slideshow? I'll give you the slideshow.
Yes, sir. Yes, sir.
Yes,
Yes,
Nidhuda.
sir.
Full
Okay.
screen, full screen.
Full screen. Okay. Now, okay.
Yes, sir.
Now,
Yeah, continue, sir.
okay.
Yes, good.
Now, radical vaginal exectomy with extraperitoneal pelvic lymphanectomy has been popularly known as Mitro's operation, and it is done in cases of carcinoma of the cervix 1B to 2A. Now, it is named after Dr. Subodh Mitros, and he was the person behind establishing the Chittaranjan Cancer Hospital in Calcutta in 1950, now still functioning as Chittaranjan National Cancer Institute. Now, actually, initially what happens, I am told to see the cervical stump carcinoma. But later on, because of the cervical stump carcinoma, video was not clear, so they advised me to present the Mitro's operation as like Dr. Bokshi. Then I told them that there will be repetition. But Dr. Mishra tells there is no problem because it is an rare operation, so you can present that. Anyway, my slide was on cervical stump carcinoma, the PPT, but the video was on Mitro's operation. So types of cervical stump carcinoma, if it is present 2 years or more following a subtotal hysterectomy, is considered to indicate true cervical stump cancer. Whereas an interval of less than 2 years following a subtotal hysterectomy is considered as coincidental carcinoma that may have been present at the time of subtotal hysterectomy. Now I'm giving a short history. Mrs. RD from Lilua, Howrah, 55 years, para 6/0, all full-term normal delivery. The last childbirth was 24 years. Had a subtotal hysterectomy elsewhere 5 years back due to postmenopausal bleeding without any prior biopsy, and at the age of 55, the ovaries was conserved. And she came with a complaining of white discharge with pruritus and dysuria. On examination, young condition was fair, and there is no clinically significant lymphadenopathy. The breast was nothing abnormal detected, and per abdomen scar was healthy, and the vaginal examination shows an ectocervical growth 2 into 3 centimeter approx, bleeds on touch, and the parametrum was soft. Rectal examination, nothing abnormal. Investigations was done as a routine baseline investigations within normal limits. Cystoscopy as the bladder trigone and both ureteric orifices normal. Histology from the cervical growth shows a grade 2 squamous cell carcinoma. MRI cervical SOL, both para and paracolp was free. Bladder and rectum was free. CT scan and a heterogeneous soft tissue density in the cervix. Other structures was nothing abnormal. Management was done in extraperitoneal bilateral pelvic lymphadenectomy followed by Schauter's operation. The postoperative histology shows squamous cell carcinoma of the cervix, and out of 18 nodes, none were metastatic. Both ovary, tubes, vaginal cups are free, no lymphovascular space invasion, and perineural infiltration. And the last follow-up was no evidence of any disease. Now, advantage of these radical Mitro's operations. Now, less invasive dissection in comparison to Hardheim's, and therefore this complication. More vaginal cup and parametrium can be removed because in radical vaginal hysterectomy, the clamp are placed in a divergent way, whereas in abdominal Hardheim's, the clamps are placed in a convergent way. That is the most important part to remember. And this is suitable for obese patients. The main advantage in learning this operation for the newer generation is that in experience gained by doing this operation, that can offer a radical trachelectomy in selected young patients who wish to preserve their fertility. That is one advantage. Now, high-risk patient can be managed with radical vaginal hysterectomy and extraperitoneal lymphadenectomy using loco-regional anesthesia. There are some disadvantages. In every operation, there are some advantages, there is some disadvantages. That is more paraoperative hemorrhage, because there are 3 incisions, particularly vaginal part, there is little bit hemorrhage, and number of incision is 3. But here, as Dr. V.D. Mukherjee has pointed out, my respected sir, that by laparoscopy, by doing this abdominal part by laparoscopy, the tying of the uterine and the ovarian and lymphadenectomy, the morbidities and the hemorrhage will be much less. He has rightly pointed out. But at that time, there is no laparoscopy, I think, in Calcutta. Now, selection of the case is most important. That is the very, very important. Clinical staging and imaging, particularly MRI, is preferred. And we should avoid an endocervical adenocarcinoma, because this endocervical adenocarcinoma usually involves the bladder base. Bladder base involved is very difficult to dissect the bladder from below. So this assessment of bladder base by clinically and cystoscopically and by MRI is very much important in selecting cases for radical vaginal hysterectomy. Now, inferior epigastric artery, as Dr. rightly said before, and the speaker, that sometimes by giving traction, there is much hemorrhage. But with the gentle traction and with the help of the assistant, if we can preserve the inferior epigastric vessels, then the union of the abdominal scar is better. And the co-surgeon's role very much important for proper peritoneal retraction that leads to an excellent view of the rectal space. And suture of the lower part, that is also an important step. Lower part of the external oblique aponeurosis with the conjoint tendon that will prevent inguinal hernia lateral. There are some tricks. The lateral vaginal wall retraction, there is a special instrument for lateral vaginal retractor. Identification of the ureter in the lower part, the bladder dissection anteriorly, and stay suture in both anterior and posterior peritoneal folds before delivering the uterus or closure, so that the peritoneum can be sutured, and a tight vaginal pack with roller gauze that will prevent oozing or bleeding in the post-operative period. Now, observation. Now, the prognosis of the pre-cervical stump carcinoma is 2 or 3 times more favorable than for coincidental cases. The individualization of therapy depends on the tumor stage, volume of the growth, the depth of it. What is more important is regular cervical screening following a subtotal hysterectomy is essential. And the rectal, bladder, and sigmoid complication following radiation, if needed, has been reported due to loss of protection offered by the intact uterus. Now, I'm seeing in video. Now, there are 3 points that Dr. Bookship previously mentioned. Right side is the McBurney's point, the pubic tubercle below, and the umbilicus level above, and we cut the skin along the line of incision and opening of the external oblique aponeurosis in the lower part, and the upper part is the part of the external oblique muscle. So lower part is the aponeurosis, upper part is the muscle. Then we identify the round ligament, clamp and cut in between and ligated. Sometimes is bleed, and this is the inferior epigastric vessels. So we are cutting here and then doing this lymphatic retraction of the peritoneum medially, identifying the great vessels, the obliterator umbilical vessels, the obturator nerve, the external iliac vein, the anatomy, pelvic anatomy. Then we ligate in between clamps and cut the uterine vessels at its origin. Now here is an important thing for learning for the juniors, that extraperitoneal ligation of the internal artery in cases of, say, secondary postpartum hemorrhage or any other hemorrhage, but the abdomen is full of blood, you can't approach. Here is the important of tying the internal artery extraperitoneal. That should be learned, that should be practiced for the juniors. Then after the lymphadenectomy, we suture the internal oblique and transverse abdominis in one shot, and the external oblique and another. Now in the vaginal part. Now it is a shoe-cut incision. Now shoe-cut incision, Dr. Nagan Rajchari used to say that it is a vagino-levatoro-perineal incision. First of all vagina, then the levatoroni, then the perineal incision. And then the overt speculum, self-detaining overt speculum is applied. And Dr. Bukshi has rightly said that as much as you like, you can hold with the Walker's artery forceps the margins of the vagina, and you incised all along the cervix and the vaginal margins by traction and counter traction. It is now incising below posteriorly by finger. You are pushing the rectum back, and lateral dissection for the bladder dissection and ureteric dissection. And that is important for this assistant to retract laterally by this lateral vaginal wall retractor, so that the lower part of the ureter is not damaged. Now when the cup is ready, then we replace with the cockers by special forceps called mouth tooth forceps. Now this mouth tooth forceps is applied anterior and posterior vaginal wall for better retraction and better dissection. So this is the lateral dissection, so that the ureter goes up. The ureter goes up. That is the lower part of the ureter at the tip of my scissors. So here it is very much important and careful, and experience is needed so that the ureter is not damaged. Then the anterior fold of the peritoneum is opened. The fundus of the uterus comes down. Here is special instrument cat's paw, but it's not needed right now. But if it is available, cat's paw, like a forceps to deliver the uterus, and holding the ovaries and the fallopian tubes with the sponge holding forceps, incising the peritoneum above without any bleeding or a little bleeding, because the infundibulopelvic vessels already tied extraperitoneally from above. She is just incising the peritoneum, covering the infundibulopelvic vessels. And you can identify the suture, which is kept a bit long to identify that it is removed. And the parametrum, so much of parametrum is removed. And lastly, the vaginal margins is closed like a vault of the vagina, leaving the middle portion open for tight vaginal packing. So here suturing either continuous or interrupted as the surgeons like, and leaving the middle portions open for the tight vaginal pack. So I'm just giving an continuous stitches throughout the margins of the vagina. And this vaginal part is bleeding, little more bleeds. And lastly, we close the Schucher's incision. First of all the vagina, then the levatorinae, and the superficial perineal muscles, and the skin, as like as episiotomy stitches. Now giving a tight vaginal pack and a Foley's catheter later on. This is a pack given soaked with betadine and the specimen removed with adequate margins of the vagina and the tubes and the ovaries. So thank you very much. Now I am very much grateful to some of my teachers. Like Mitro's operation I've learned from Chitranjan Sivasodhan, Dr. Ellen Ghosh, then Dr. Shobha Ghosh, then Dr. Sujit Banerjee, and also I am very much grateful to Dr. B.D. Mukherjee and Professor Biman Chakraborty for learning also the Vardain's operation. So in one way, I am very lucky to do both the operations, vaginal, Mitros, and the Vardain's operation. Thank you very much.
Tulika, may I speak?
Hello?
Can you hear
Yes,
me?
sir. Yes, Dr. Chakraborty.
Yes, sir. Yes.
Anyway, I'm sorry for what has happened. Now you can hear.
Yeah. Sir, you're very clear now.
This platform is of SOVSI Bengal and the Society of Vaginal Surgeons of India. This is headed by Dr. Shirish Sheth, my long-time revered colleague and founder president, Bengal chapter, Dr. Sukanta Mishra, my student. I would like to thank you for inviting me to this virtual August gathering as a faculty. It is interesting that gynecologists has to revisit this expertise in vaginal surgery and prove that in many conditions, vaginal route of surgery gives better results than any other route. And Indian gynecologists, including Professor B.N. Chakraborty, Dr. Shirish Sheth, and Dr. Sonewala, had always kept their footprint internationally. Tonight, we will be discussing vaginal surgery for malignancy only. I had the good fortune of being a student of legendary late Professor Subodh Mitra and used to be amazed by his surgical dexterity in vaginal surgery in cervical malignancy. Today's orator, Dr. N.R. Mandal, is my colleague of Saroj Gupta Cancer Center and Research Institute, Thakurpukur, for the last 30 years. He is an excellent versatile surgeon and will be showing us radical vaginal surgery, but we couldn't see the video. I'm sure we have all enjoyed this talk, and he is also an academician and interested in clinical research. He has published several articles in national and international journals, and I wish him good luck, and I'm sure he will be more successful with his job. He is one of the few teachers who can teach the younger generation how to do the Mitra's operation. Thank you.
Dr. Todani?
Yes.
I think there's one question, I think. There are quite a few comments.
Tulika, tell
This
him
question for whom?
Tell him the question.
Oh, it's for both, I think, because the question is from Dr. Shivani Sengupta, and she wants to know how to choose cases of, for doing Mitra's operation. Which cases will be best suited for Mitra's operation? And I think the question, there's only one question, and otherwise, Dr. Alka Seth, Dr. Amit Basu, Dr. Orunabhu Roy, everybody has complimented the surgeons on the beautiful surgeries.
So who is going to answer the question?
You pick up one.
Dr. Nidhu Ranjan Mondal.
Dr. Enal Mondal. Dr. Enal Mondal, please.
No problem.
Dr. Enal Mondal, please.
Am I audible?
Yeah.
Yes, you are very much audible.
The best suitable case is stage 1B, and if there is some little bit of prolapse, if there is a little bit of vaginal prolapse, it is very easy to do a radical vaginal hysterectomy. And the bladder squamous cell carcinoma, not adenocarcinoma, and the bladder dissection will be very much easy. The prolapse case, not the third degree, it is either a first or second degree uterovaginal prolapse cases with carcinoma cervix stage 1B is the best suitable candidate for radical vaginal hysterectomy, in my view.
One question of selecting the patient is by clinical examination. That is, we do in the vaginal examination as well, we do the rectal examination. And by this, we can well understand the extent of parametrial involvement. If it is more than 2/3, that is, we are careful in selecting the cases. But if it is very soft and only 1/3 is involved, the case is being very comfortable to do Mitra surgery. Rectal examination is very important, and by this we can
that is
extent of the growth to the lateral pelvic wall.
Yes.
So Professor B.N. Chakravarti wants to say something. Sir, can you unmute yourself?
Pre-operative staging. Yes.
Pre-operative staging. Yes.
Yes.
Professor B.N. Chakravarti, sir, can you unmute?
Promotesh Da is saying something, Shamulda. Yes, Dr. Mohapatra.
Promotesh Da, bolo.
Yes, I think the pre-operative staging is very important for the selection of cases. As Enal Mondal said, that the stage 1A and stage 2B stage 1, stage 2A. These are the cases which can be managed very efficiently by Southern suppressor or Mitra suppressor, what you call. I have an inquisitive here. Can I ask both of you, please? As Professor B.N. Chakravarti is here, Bhiman Chakravarti is here. Why the Mitra suppressor did not get any popularity outside Chittagong Cancer Hospital?
Let me answer. Because due to the modern advent of the laparoscopy, and that is one point. Number two, it is a time consuming. Number three, 3 incisions are given, 2 on the both sides of the abdomen and 1 in the vagina. And it is a very technical operation, and it requires years to learn this operation. That's why it is not very popular throughout India.
No, but obviously you got the training, Enal Mondal got the training. But why it spread all along the gynecologist of India and outside India?
That is the love of the subject, and the love of the subject, and the one who wants to learn the surgery. This is the surgery by which one can learn the vaginal surgery. This is very important. Love of the subject.
No, no, I'm not talking about the vaginal surgery. What I'm talking about the cancer surgery by the method. I think Dr. Biman Chakraborty will be able to answer. Why,
Yes, I
my
think
feeling is that, I remember once upon a time, Dr. B.N. Chakraborty demonstrated once, but then Mitras operation at PG hospital because one gynecologist from Singapore requested him to demonstrate one Mitras operation. So it was a rare occasion when the international faculties came to witness our surgeries. And even in India or in West Bengal, you see the mitral operation is not very popular. People are going for Southern operation or maybe for burdens hysterectomy. Why is that? Why we fail to popularize this technique? It's a lovely technique. It has got many advantages, but still it got restricted within the walls of the cancer hospital, Chittaranjan Cancer Hospital.
Most probably, Prabhudas Da.
Professor Biman Chakraborty.
I want to learn from Professor Biman Chakraborty.
Yes.
Some comment from Professor Biman Chakraborty and some comments from Professor B.N. Chakraborty.
now,
Sir, can you
unmute
yourself, Professor B.N. Chakraborty, please?
Sir, unmute please, B.N. Chakraborty, sir.
Support team, can you unmute Professor B.N. Chakraborty, please?
Then let us hear from Professor Biman Chakraborty, please. Sir,
May
what
I?
is your opinion? Why he did not
Yeah.
popularized?
Well, my impression is the subject itself, the patient profile is gradually changing. Previously, it used to be more multiparous patient. Now you have one or two child with very little cervical descent, uterine descent. And secondly, and you find that most of the deliveries are by cesarean section. And there the question of scar is a very important point. At the end of the day, when you have all worked for all your life, you come to a decision that which is the easier way to do it. And you can sleep without risk of any damage. And I find that perhaps in my hands now, I feel that it is easier to do it abdominally. That's perhaps the makes this difference. Otherwise, it is a wonderful operation.
Yeah.
Hello.
Sir, Professor B.N. Chakraborty, please.
There was no ambassador who would go outside world.
Hello.
Tell that this is the technique which is far superior than Southern.
Yes, sir. Sir, Professor Chakraborty, B.N. Chakraborty, please, sir, we are waiting for you.
Am I audible?
Yes, sir, you are.
Yes, sir.
I have one question. I have always asked it only to those who are very favorites of the vaginal approach. Now, the thing is this, you are doing a clinical diagnosis of staging. That is, it should be stage 1A or stage 2, stage 2A or stage 1B, but not beyond that. But by clinical examination, you are doing the staging. Are these always sure? Because at the last stage of the operation, if you are not doing by laparoscope, you are doing the radical vaginal hysterectomy plus lymphadenectomy. At the last stage of the operation, you find that you are stuck up with the bladder, and what you do at that time. And I have asked Dr. Mitro, and he said we do a cystectomy, local cystectomy. But is it enough to do a local cystectomy, or if you are doing a radical surgery abdominally, you can just get it, convert it into a extra radical hysterectomy. That is the Brunswick surgery, anterior Brunswick surgery. Otherwise, you are not dissecting or not removing every part of the cancer. Because most often, we always, not most often, sometimes it is, we have diagnosed, clinical diagnosis stage 2A, not stage 2B. Even if it is stage 2B, it is very difficult to dissect the bladder. And at that time, the bladder injury is most common. That is one of the reasons. At that time, I am talking about 1960s, when you started. At that time, radiotherapy was not very common. Many cases of cancer cervix, used to come to us and you had to do a surgery. And thinking that it is either stage 1 or stage 2A when you approached and you did the lymphadenectomy, and after that you are doing a vaginal hysterectomy. At the time of dissection of the ureter and the bladder, you are stuck up. You are stuck up.
Yeah.
It is not being separated.
That is very possible. But, sir,
Yeah,
am I audible?
Yes,
Am I
yes,
audible?
yes, Dr.
But,
Boxi, you please answer.
there are many incidences where we have to abandon the operation while doing the lymphadenectomy because clinically lymphatic extent of lymphatic involvement could not be diagnosed. And while we are doing extraperitoneally, we found lymph glands are stuck up with the big vessels. And that time we abandoned the operation. This is another field where we do while we abandon the operation. This is one field.
Dr. Boxi, that must be the story of the past. But now we have very good CT scan,
yes,
which can detect the enlargement of the lymph.
Yes, yes. Nowadays, it is very
So
easy.
I think that problem will not be there anymore.
No.
I think
was Sarah was saying surgical staging.
Clinical staging is very important, and we are to learn.
Clinical staging is a provisional staging. The final staging will be done after the surgery. Sir, am I right?
Sir, just a point. As a matter of fact, staging now includes a few scopies: cystoscopy, proctoscopy, IVP, etc., etc. So the thing has changed a bit, but what it still holds good is that stage 1B to A, if it is clinically and by investigations prior to operation is feasible to determine, then one should go for this.
Since time is short, I think we need to move on. And comments from Dr. Todani, sir, Dr. Ashok Kumar Todani, closing comments from your side?
Yes, as far as this stump carcinoma is concerned, its frequency and incidence is very much unknown. Can any one of the esteemed guests can answer this question? What is the incidence of stump carcinoma?
He told.
Sir, it is very difficult to estimate, but it is usually 1 to 2% of all cervical cancer. 1 to 2% of all cervical cancer.
Okay. With a reducing incidence of subtotal hysterectomy, definitely the incidence of stump carcinoma is also going down. We have seen lovely videos of Mitra's operation. I like to thank from the core of my heart to all the speakers, and thank you everyone who has joined this session. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir.
Thank you. Thank you, Dr. Boxi and Dr. Mondal, for treating us to such wonderful surgeries. And thank you, chairpersons and Dr. Chakraborty, for making this session so lively and interactive.
I'm very sorry that I...
No, it's okay, sir. It happens. With the technical glitches are always happening in all webinars. So
this is the problem of webinars, sir.
That's right.
That's right.
My laptop betrayed. But mobile is okay.
For the information, the technology is so advanced now. I am participating in this webinar from Sundarban.
Nice. Yes.
From Sundarban.
With the tigers.
With the tigers. I hope I could show you some tigers. Thank you.
Oh, how nice. How nice. Thank you, everyone.
Thank you, everyone.
And just one last question. I saw that, Khalida, what is the name of the forceps you used for holding the vagina, which Dr. Mitro had fashioned?
Let Khalida answer.
Mouse teeth. Anyway.
Let Khalida answer.
Yes, Khalida.
Am I audible?
Yes, you're audible.
Mouse tooth forceps.
Oh, Arunabha Roy, Dr. Arunabha Roy wanted to know that.
Inches long, and tip of the forceps are serrated by multiple tooth-like structures like mouse tooth, and that's why it is called mouse tooth forceps. It helps to grasp the vagina very tightly, and it prevents tearing of the vagina while giving the traction. That is the advantage of the mouse tooth forceps.
Thank you, Khalida. Thank you once again to both the speakers and the chairpersons. And we now move on to the second session, which I'm sure will be equally interesting. And to conduct the session, I would like to invite the chairpersons onto the virtual dais, for which I need the slides.
Yes.
First of all, I would like to invite, as chairperson, the one and only Dr. Vaidyanatha Chakraborty. I'm not going to read the slide because he actually doesn't need any introduction. And so welcome, Dr. Chakraborty. Welcome to the session. Next, I would like to invite Dr. Partha Kumar Bhattacharya, Professor and Head in Burdwan Medical College and Hospital, and also in Eden Hospital, Calcutta Medical College. He was the president of the Bengal Obs-Gynae Society in Bengal Obs-Gynae Society. He has many publications in the national and international journals, and among his many interests, vaginal surgery is one of them. A very respected teacher. Welcome to the dais, sir. Welcome, Dr. Bhattacharya. Next, we have Dr. Sudip Chakraborty, Sudipda, president. He was also the president of the Bengal Obs and Gynae Society in the year 1999 to 200. He was the president of ISOPAR from 2012 to 2014, vice president of FOXY, and the chair E-Zone RCOG in 97 to 2003. Welcome, Dr. Chakraborty, to this webinar. And we have, as the fourth chairperson, we have Dr. Pradeep Kumar Mitro, founder and deputy secretary general, Endometriosis Society, India. He's a senior visiting consultant of Obs and Gynae in Kolkata, and he was the organizing secretary, International Conference of Endometriosis 2015 and 19. He's the zonal coordinator of FOXY. He's also one of the past presidents of the Bengal Obs Gynae Society. He has been an invited faculty in FIGO conferences in many years, 2003 to 8, 11, 2015. He's also a past president of the Ex-Students Association of our college, Calcutta Medical College. So welcome, Dr. Mitro. And I hand over the proceedings to the chairpersons and invite the speakers one by one.
Let the organizer unmute Professor B.N. Chakraborty.
Support team.
Support team, please
team, will you
unmute
please
Dr. B.N.
unmute Professor B.N. Chakraborty?
Who is to introduce?
Dr. Sudip Chakraborty to call the first speaker.
Dr. Sudip Chakraborty to unmute.
Oh.
Yeah.
I think Samuel, Dr. B.N. Chakraborty is speaking something.
I know,
but he is again muted.
I know. I don't know what's happening. When support team is not responding, we're asking.
But his assistant came and supported him.
Yes,
once
please
he
accept
came.
the request.
Anyway, we will hear from sir at the end of the second speech. So Dr. Sudip Chakraborty, please introduce the first speaker and invite.
Yes, sir. Please click.
Can I please have this slide?
Yes.
Yeah.
I would like to invite Dr. Joydeep Bhaumik to start the session. He is a senior consultant gynecological oncology at the Tata Medical Center, Kolkata. I can't still see him, but I hope he is there.
Yeah, he is here.
Right. So may I request you to start your presentation?
Good evening, everybody. Am I visible and audible?
Yes.
Can you see my screen?
Yes, sir. Yes, sir.
Everything fine, fantastic. Please.
So, a very good evening, everybody. It's a real honor and a privilege to be talking in front of some of the most renowned and respected teachers from me. Before I start this presentation, I must thank once my student and currently my colleague, Dr. Aruna Horai. This operation is actually undertaken by him. He is the person to be looked forward to in the future. I think is a star of gynae oncology for future for this town. So I was only the photographer of this video presentation. The rest of the work was done by him. So
please make it full screen.
Is full screen now? Yeah.
Right.
So the operation is called a modified radical valvectomy, but I think we should call it a modified simple valvectomy because, I mean, my stalwart teacher said here, I mean, 15, 20 years ago, valvectomy was such a mutilating operation, a lot of bleeding, problems with wound healing, wound breakdown, and all these things were happening. But now with the advent of knowledge, now we understand the biology of the disease a lot better. The radicality has now become very minimum. What we need to do is to get a proper margin, an oncologically acceptable margin along the tumor, alongside the tumor. And of course, the other part of the procedure of a valvectomy operation is dissection of the inguinal nodes. Now, today, I'm restricting my talk to the modified radical valvectomy only. So this patient is a 72-year-old hypothyroid patient from Jharkhand. She had a 6 months history of left valval growth. She couldn't attend the hospital because of the lockdown. And she had a biopsy which showed moderately differentiated invasive keratinizing squamous cell carcinoma of the vulva. As a staging procedure, we were discussing staging before about cervical cancer. Now we have a lot more better modalities to select our cases for surgery. We normally undertake an MRI pelvis to delineate the tumor, make sure there is no extratumor extension, to assess the lymph nodes. And we also do CT thorax and upper abdomen for a metastatic workup, because no point operating on the vulva if we have a lung metastasis. So we always do a workup like this before we choose our patients for surgery. So the MRI pelvis showed about a tumor which is less than 5 centimeters in size, and there was involvement of the lymph nodes. So after the basic investigations, we need to reiterate the size of the tumor. One thing that is important in decision making for the surgery is the distance from the midline. Distance from the midline, the reason is that if the tumor is well lateralized, then we do lymph node dissection of that side only. But if the distance is less than 1.5 centimeters, sorry, there's millimeters there, less than 1.5 centimeters, and if the labia minora is also involved, then of course we will need to do bilateral lymph node dissection. So this one is within that 1.5 centimeter of the midline, and the size of the tumor, as we can see on the scale, 4 centimeters in transverse direction and 5 centimeters in the longitudinal direction. So this is a reasonably large tumor. With that, we would mark the outer margin of the tumor with a marking pen. Once we have done that, then we need to take a 1.5 centimeter margin all around. Now, the reason we take 1.5 centimeter margin is because a pathologist, when they receive the sample, it will be it will be in formalin, and the tumor will shrink. Now, if the tumor shrinks, what we need from the pathologist to tell us if the cut margin is more than 8 millimeters. If I have not taken a margin more than 8 millimeters from the resection, then the surgery is not adequate. So the radicality depends on how far I have been on the from the specimen and the microscopic lesion. So to be on the safer side, we would take a 1.5 centimeter margin from the lesion. So that is how we are marking the lesion all around. So taking 1.5 centimeter from the margin of the disease, as far as we can see. So we go all around making small dots, and then once the dots are made, we'll be joining the dots to make a line for the. Now, one thing important to remember: when you do vulval surgery, it's very moist area, and your pen sometimes doesn't work. So you have to keep on shaking the pen and then apply the mark, because this planning is the most important part of the entire surgery. If the planning is incorrect, the surgery will be incorrect. So what we are doing is the assistant is constantly drying the area, and a line is being drawn between the dots that we have already made. 1.5 centimeter margin all around is extremely important. Now we are rotating, the lateral vulval area has been marked. We are rotating the incision mark towards the midline. So the vaginal, the vestibular surface is now exposed. And again, the same principle, the assistant keeps the area dry, measuring from the edge of the tumor and taking 1.5 centimeter margin. It is extended all around. It's important to make sure that the area is not moist when you are marking the pen. Now here, once we have planned our surgery, the equipment we will be using is something very important. Now, of course, with modern technology, with modern equipment, we can actually do a completely bloodless surgery. What we're using here is a needle tip diathermy machine, and the current that is being used with is very, very small. So because of the body is, if I'm cutting the skin with a diathermy, it may not heal well. But if I'm using a needle tip and the cautery strength is only 15 watts, you can see it is cutting so nicely, and there will be hardly any bleeding during the entire procedure. So a needle tip cautery with 15 watts in coagulation, 15 watts in cutting mode. And we use a blend current for the entire procedure. So the first thing is to do is to mark the entire incision. Very fine cut mark is made using the needle tip pen diathermy is made all around. So just a scoring of the entire area done with the needle tip diathermy. Now we are lucky in this patient that the clitoris was not involved, and we had enough margin from the clitoris. Once we have done the skin, then the next step is to go into the subcutaneous tissue. We can actually increase the diathermy power at this level once the skin has been incised, because you're not actually cutting the epithelium with the diathermy. But we normally keep to just 15 or 20 watt of current at this stage. So the next step is to cut, again, remain perpendicular to the skin. So the traction and countertraction is extremely important, so that you are remaining at that perpendicular plane and cutting the subcutaneous tissue. So we are not going deep just as yet, because the main idea of doing the entire procedure in this way is to make sure that we take the dermis and epidermis and the subcutaneous tissue in a proper way, so that the superficial layers are taken properly. As you can see, there's hardly any bleeding. And now let us just understand the blood supply of the perineal area. The most important artery, of course, is the internal pudendal artery. And what we are interested in mainly is the perineal branch of the pudendal artery. The perineal branch, once it crosses at the level of the deep and the superficial transverse perineal muscles, between these two, they branch in like a fan. So one artery goes in front, main artery goes towards the anterior region and supplies the clitoris and gives off several branches, mainly to the bulbus spongiosus and the vestibule in this region. The other important branch is so it divides into two: the upper part and the lower part. And this is the one we look very carefully at, because this is the one that bleeds during the surgery. So we have to identify the perineal artery, the posterior branch, and the anterior branch. And to do that, this is a nice technique that you actually do not have to cut through directly. Use a forceps at right angles and identify the possible area. And using this, the equipment we are using is it's called ligature. So it helps in coagulating and cutting at the same time. This just saves time. If you do not have this ligature, you can use a simple clamp. You can use diathermy, whichever way you can. Standard diathermy machine at any. So we are, again, as I mentioned before, cutting things at right angles. You are going deep So making sure that you have enough tissue left. Whenever you are cutting a tissue, always remember that you have to reconstruct. You have to bring it back to normal shape. Now, once we have gone through the subcuticular tissue, the possible areas of the branches of the arteries, of the perineal artery, should be nicely demarcated. So this is the again, we're using the ligature to dissect the vessels, cut and ligate at the same time. And if you can watch, the direction of the dissection is always perpendicular to the tissue, what we do, because we need to go deep. We need not only 1.5 centimeter margin at the lateral edges, we need 1.5 centimeter margin at least in the deeper tissues. And that's how we are getting into the planes of the vessels that are supplying the vulva, the middle part of the vulva, and coagulating and cutting it at the same time. Now, as I showed in the previous slide, we were more concentrating on the transverse perineus muscle and the branches along with it. And now we are concentrating on the anterior branches, which is a branch of the perineal artery, which is supplying the clitoral region. Again, keeping the area dry, keeping the area completely avascular, identifying the fat planes, and then identifying the stumps, not really the stumps as we see in major arterial surgeries, but because these arteries are small, trying to cut and identify the vessels sometimes is difficult. So a blunt dissection, like the way we're using a right angle forceps, usually very nicely, clearly demarcates or helps to get the vessels, and the surgery becomes completely avascular. So now the important part is that we go to the depth and we go up to the level of the perineal membrane. I'll come to the perineal membrane in a little bit, but at the moment, what we are doing, we are dissecting. Probably you can see at the tip of the right angle forceps that the perineal membrane is actually visible. The shiny surface you can see is the perineal membrane. Once you have gone to that level, it is just like a circumferentially identifying and demarcating the stumps and dissecting and then cutting with the ligature. It's a very handy, easy and safe equipment. But again, if it's not available, you can ligate and tie with standard clamps, and at the same time, you can use a simple diathermy machine to do the same work. Medially, it is important that, of course, the vagina is extremely vascular. So ligature is actually very helpful in this scenario. Identifying the vessels, cauterizing them, and taking it off the. So we have actually taken the depth. We will show you how deep we have gone during the surgery, right up the perineal membranes. The assistant is actually giving traction onto the vulval skin. It is important to remember that sometimes we are taken away by the joy of doing surgery and forget about keeping appropriate tissue for reconstruction. So again, identifying the vessels, the vessels supplying the bulbous spongiosum muscle, and the clitoral area, and cutting it. So as I said, it's really a simple operation. Previously, what we called a radical vulvectomy, modified radical vulvectomy. Now I prefer to call it a modified simple vulvectomy. Now that's where the perineal membrane is. That will be my limit of surgery for this patient. This is the perineal membrane. Now, those of you who are vaginal surgeons will know it more than I do, that this is an important landmark in perineal surgery. And this is forming the caudal end of the perineal pouch. Now, the perineal membrane is at the bottom end, and above is the as a deep perineal pouch. So in the deep perineal pouch, you have some important muscles. We try and restrict ourselves to the perineal membrane. Reason is, in the deep perineal pouch, you have the sphincter muscles of the urethra. In the female, it's only a 4 centimeter of length that is available for continence. And if I am venturing through the perineal membrane, I can actually disrupt the continence of the patient. So if possible, if I have taken enough margin in the perineal area, this is my extent of the dissection. So the perineal membrane, that's why identifying the perineal membrane and remaining on the superficial to the perineal membrane is extremely important. So that's what we have done over here, dissecting up to the level of the perineal membrane. And here we have been able to spare the clitoris, but the entire the vestibular glands will actually be removed along with the tissue over here. It all depends on the location of the tumor and what are essential and what are not essential. The reason I mentioned very particularly about the perineal membrane and the deep perineal pouch is that importance of the continence of the urethra. As you can see, we're very close to the urethra, but we have been able to preserve the functioning of the urethra. Even if when we remove the catheter, she should be passing urine normally without any incontinence. The upper margin, of course, is the pubic rami. So we have to be able to identify the bones of the pubic rami. We'll demonstrate in a few minutes. Again, the assistant is retracting and showing it to the surgeon that how deep you need to go. The vestibular gland and everything is gone. So the muscles, of course, the bulbospongiosus muscles and the ischiocavernosus muscles that are to be preserved. What we are demonstrating here, the top one is the ischiopubic ramus, where the forceps is. This is the bulbospongiosus muscle that has been preserved. The vessel, of course, was cut at this area, but the muscle could be preserved. The vaginal margin is intact. Of course, not much blood loss over there. Pubic ramus, perineal membrane, and the so this is all we needed to excise from the as a specimen. Just putting the specimen back in the place. So this is what it was before. The specimen is removed. We have left enough fat on the vulva on the normal side to be to make sure that the suturing is fine. So we suture it in layers. Normally, depending on the depth, usually we do it about in 3 layers. The first layer is to go deep right up to the level of the perineal pouch, perineal membrane muscles. And the main reason of doing of course, there's no solid structure to tie to. The main reason is to make sure there's no dead space, so that there's no collection and there's no breakdown of the bone. As you can see, the surgery was absolutely bloodless. There's no, now you have got a blood loss, because this was the area where the perineal, the perineal artery was supplying. Of course, once you've taken the suture, tie it quickly so that there's no blood loss. This can happen, and that can happen in any surgery. The moment you see a blood loss, we just tie it, and in different layers. The first layer is done. Now we're doing the second layer, bring the vaginal margins closer. Of course, Professor Giri will show reconstruction of the vulva. We were lucky in this patient that we didn't have to remove much of the vulval region. So aesthetic way was properly maintained. We didn't have to reconstruct in this case. But if we had to remove a lot more of that area, then a reconstruction would have been necessary. This is the reconstruction should normally be done by the gynecological oncology surgeons. We don't need a plastic surgeon to do this. It's a very simple procedure. Of course, in this case, we are doing a simple closure. Now, the suture that has been used in the deeper layers was a Vicryl 30 dyed Vicryl. Now, the suture we are using on the perineum is a Vicryl Rapide undyed vertical. It is undyed, so there is no mark on the skin. And second is, of course, it dissolves quicker compared to the standard vertical. So it's just simply bringing the skin together, and at the end of the surgery, it should look as close to the previous normal vulva on the other side as possible. This lady subsequently had a lymphadenectomy. We have started, Orunabo is pioneering it, a robotic lymphadenectomy, and you'll be amazed to see that how nicely it has been done. Hopefully in a future session, we will be able to show it, that without making an incision on the skin, the main problem of lymphadenectomy in vulval surgery is, of course, wound background and prolonged recovery. This doesn't happen with minimal access surgery. But for me, this is what I wanted to present, previously called a radical or modified radical vulvectomy, which I now call a modified simple vulvectomy. Of course, before you end, you have to check the urethra, make sure there's no incision or no stitches in the vagina. And last but not the least, you have to check the rectum. Put a jelly on your finger and just put a finger inside the rectum, make sure that your sutures have not gone through. If it should not happen if you are careful during your surgery. If it happens, then of course you can have to take the sutures out. Thank you very much for your attention. I'm happy to take any questions if there are any.
Thank you very much, Dr. Bhaumik. That was an excellent job. And it was very interesting for me to watch because this is something that I haven't seen before. We have seen radical vulvectomies.
My pleasure, sir. I also thank you on behalf, I thank Orunabu on behalf of my team at Tata Medical Center. Sometimes we feel very, very proud of having excellent students who will take forward the legacy, the thing that happens in Bengal. And I'm really looking forward to that in the future.
Thank you very much.
So I would request Dr. Parthu Bhattacharya to introduce the next speaker.
Am I audible?
Yes.
Yes, sir. Yes, sir.
Well, before I introduce this next speaker, I just want to make one comment about the wonderful presentation of modified vulvectomy.
Hello, sir. Sir, you are joining with two devices. So there is coming echo from that. So join with only one device. Sir, you are muted, sir.
Unmute him.
Please unmute him.
Yes, sir. Yes. So please accept the request.
Okay.
Now it's okay.
Okay. Now, Dr. Sushil Kumar Giri, you can see this slide because my laptop was giving trouble, so I had to switch over to my smartphone. And he has got ICOG award oration and in Thrissur, organized many national and international conference, publication, there are many, and examiner in gynecological oncology and Bangalore and St. John's College, Rajiv Gandhi University of Health Science, Karnataka, CMC Vellore. Now, he will talk about the reconstructive surgery, or can I read it?
Yes.
His topic is reconstructive surgery.
Following vulvectomy.
Following vulvectomy, yes.
Yes, yes.
Now, Dr. Giri, this floor is yours. Please.
Thank you, sir. Thank you, sir. Thank you, the organizers, for asking me to be a part of this webinar. So let me share my screen now. No, it's not visible. I don't know.
Sushilda.
It's not coming.
You are seen, but your voice is cracking.
No.
In the bottom side, there is a green color option. Named share screen.
Yeah, this share screen is there, but I've opened it in my computer. It's not coming. And let me see. Just give me some time. I've already seen it there. Where is it gone?
Surgery on malignancy always will have some glitches.
Yeah,
it's not the technical glitches only.
Yeah. It was there. I don't know where it's gone. Oh, not open. Okay.
Yes, sir. Open your presentation in the background.
Yes, I've already opened it. Now let me see whether it is.
So in the bottom side, there is a share screen button.
Yeah, I'm going for it. Yeah. Yeah, now I could get it. Okay.
Yes, sir. Please make a slide, sir.
Yeah.
You have to cancel it.
Cancel, na?
Yes, sir. Click on cancel.
Okay. What is this? I don't know what is going on. Okay. Thank you very much for the organization for asking me to be the part of the webinar. So once Dr. Jaydev has already done the job and he says closure primarily. So there are many issues which will come out when the region is very big. Already he has told that if the regions are big enough, there will be difficulty in closing a primary intention. Very difficult now. So now treatment of vulvar lesions, both benign and malignant. So I will touch something about some benign lesions also. So once we do the surgery, all things, it has a major impact on patient's self-esteem, body image, sexual identity, and sexual function. Yes, definitely. If you just do a surgery and close it, there is a lot of problems when it comes primary closure. So conservative surgeries, now people are thinking of, as Dr. Bhomik has told, it is modified radical, not modified simple vulvotomy. So people are thinking in terms of really more conservative nowadays. As we see in our student career, there was huge vulval gap, and it was getting dressing for months. Patient was used to stay. So now that's why we have got the modified radical vulvectomy, or you can say, as Dr. Bhomik's language, the modified simple vulvectomy. Yes, that is the talk of the today's in management of vulval malignancy. So vulval reconstruction with large defects after surgery. So it is for sexual functions. It is for bladder and bowel integrity, and basic problem of primary tissue healing is there. That's why people are thinking that we to reconstruct the vulva after surgery, either primary reconstruction, which is done by Dr. Bhomik, or it may be done by other methods. So now primary closure is possible, and because there is laxity of skin, all things are there, but what happens? The interiors get narrowed mostly. In many of the cases, we see the interiors getting narrowed. And just see this video now, and you will see the small lesion, and we go on doing the surgery. Same thing. This was almost same case as Dr. Bhomik's case was there. So we usually give this infiltration of the adrenaline infiltrations just to prevent oozing, local oozing. We can usually prevent, and we take around 1.5 to 2 centimeter margins. If it is nowadays, margins are not taken into account much. And people are thinking that say only 1 centimeter margin will be sufficient. All things are there. These are all controversial issue. But what we do, we just give a marking either by this the knife on the other side, the non-cutting side, and we cut it in a very deep way, deep to the inferior layer of urogenital diaphragm, or you can say this is the perineal membrane. Now this region is a then on the vaginal side also we have taken around 1.5 to 2 centimeter, and what happens after that, and we go deep into it, and you will see how deep we will go in it, and you will see the very glistening structure, which is the inferior layer of urogenital diaphragm. Then I will show in the other slides, other videos are there. This is a video to show how primary causes this is the vulva gets, the vagina gets everted. So now, yeah. So this is the huge, this is the gap which is there, and I thought of that we can do a primary closure in this particular case. But after this thing, we find there is a vagina is narrowed, vagina everted, and you can see the vagina is now, you see the vagina everted. The more vagina everted, there is chance of vaginal infection, vaginitis, and this is the huge vaginal growth, but it could be again closed primarily, and this is the margin of the vagina, margin of the growth which we could done it. So problem arises in the presence of large. If it is a small lesion, yes, we could do it in a primary closure, could be done. But when there is a large lesions and lesion over perineal body or mons pubis, primary surgery or radiation has been done earlier, and there is a large defect. The large defect can be covered by skin grafting, use of flaps, and allowing healing by secondary intention 6 to 8 weeks. It can take long time to heal, rather more, not less than that. So it becomes a lot of troublesome for the poor women. That's why the skin grafting, yes, this area, this split thickness skin graft does not take, because the area is never a static area, it is a mobile area, and the skin graft will not remain viable because there is delayed healing or graft loss, or graft will be rejected commonly, and after it is healed, there will be contracture will be there. Contracture, the more the contracture, there is less the function of urination or intercourse will be definitely difficult for the woman. So other flaps are there. What are the other flaps we use? We use myocutaneous, fascicutaneous, based upon subcutaneous islands, or one can use free flaps, or there may be advancement or rotation or transposition flaps, but they are used in when there is chance of high risk of breakdown and when the cosmetic results is likely to be poor. So now, what we commonly do in our place is that it is lotus petal flap. This is a lotus petal flap with a rich arterial blood supply in the perineal area from the terminal branch of the internal pudendal vessels. So this is the flap is from line of the petal of the lotus flower. The flap requires isolation and preservation of deep perforator of the region and includes deep facial layer. Width of the flap should be at least equal to the width of the. This is the width of the flap should be equal to the width of the region which is there, and these flaps have a proven robust, simple to perform, and cosmetically extremely acceptable with minimal morbidity at donor site. I'll come in little of this. So always I tell this A, B, C, D. Not anybody can dance, but anybody can do it. This can be done by anybody who is little interested in surgery, and if seen once and try once, one can do it. There is no difficulty at all. We don't need any help of plastic surgeon at all. So this is the lotus petal flap in small lesion. You can see the lesion is there. I call it a small lesion, and how we have put the lotus petal flap and what is the outcome of this. Again, I have put this small. This is the incision is there. Again, we're taking 1.5 to 2 centimeter. Usually, I don't measure, as Dr. Bhomik is very particular, very particular. He does everything in a scientific way. I do it in a scientific way, not in a very particular way. So you can see this is the superficial fossa, and I go up to inferior layer of urogenital diaphragm. I will see, and you can see the urethra here. What happened? It is coming back again. Okay. So we can see now. Now you can see these muscles. You can see the muscles are there. The bulbous major muscle is there. We can go up to that. This is the inferior layer of urogenital diaphragm, and one should be very careful. Yes, the margins should be really definitely the definite role in margins, in the sense that it should be free of the disease. Otherwise, the total surgery will be a flop. So now I do everything with this monopolar cautery, and sometimes when there is bleeding, we just do the cautery with the bipolar coagulation is there. And here there is a role of the pudendal vessels are there, perineal branches, and usually I either cauterate it, or now this is the big gap now. This big gap needs to be filled up. So this is the lotus petal flap. This is the flap which is the perineum. This is the from the perineum. It is coming back. So the flap, I'm taking it now. Now just the apex of this wound is now closed, so that we can now you see this is the flap on this side. The other one is gone somewhere. Let me see. Just a minute. I'm sorry. I could. So this is the flap on this side. This is the just like a petal of the lotus flower. And what we do, just see. Usually I try to avoid cautery here because the vessels which we were dependent on it, the perforating vessels may get clogged up. So there may be this the graft recession, it may get rejected. You can see what is going on here. This is now this is now put into at this apex, at this angle, and this flap from this side is going up. Now you can appreciate. Now I put, usually I do not do what happened here. Usually I do not do this layer closure because it has got a lot of fibrosis may occur. So I put this is negative pressure drainage here, and usually I don't repent for it, and hardly I do get any graft rejections. This you can see the negative pressure drainage is here. This is the Thompson drainage is there, and what I get, I put this stapler, and now you see this. This is the type of closure is there. And this is how final outcome is this, and you can see the final outcome here. This is the reason. Okay. So when it comes to this is the large locally advanced disease, so it becomes difficult. Now we can see the large lesions is there. So here what I do, we have to mark it in the marking pencil. It is very difficult because very difficult to get the margin, and as we see this so you can see, I'm going deep to the urogenital diaphragm level, inferior urogenital diaphragm, and you can see here the growth is little bit of very close to the clitoris. So I have to somehow remove clitoris. I'll see how it is being done, and it has gone onto the to the this left side also. Now you see this is very close to the urethra. I am going very close to urethra now. You can see it's very close to urethra. So one can at least cut the distal portion of urethra. There is no problem at all. But because it was very close to urethra, at least 0.5 centimeter of this is the clitoris. I have to remove this. And on this is the vaginal margin of the growth, and dissection is done in this way. And so here one should be very careful about the rectum. Very close to the anal canal is very close to it. So it is put one finger into it before cutting it, and very careful about, because yes, there is chance of injuring the rectum. And here the same thing again. The upper portion is closed, little bit approximated. This is the upper apex is approximated, and now this is again the same lotus petal flap is used. I am very happy with this flap, because we have done around 70 cases till now with this flap, and I don't repent till now. Then there is no much, or there is no not at all the graft rejections, and usually I try to avoid this cautery. Yes, for that reason only. Now you can see how happily the gap is being closed. Again, the Ramson this drainage, vacuum drainage is put it. I give this vehicle 30 inside to close this gap, and this is how this looks so nice. And you can see the post-operative picture after one. This is the post-operative scar, and one more scar is here. This is post-operative scar is here. So this is the final picture, and there is if the lesion is really large, there is a chance that we may have to take the help of plastic surgeon. So this is the extensive vulvar malignancy. This is the huge growth which is involving, and we have given she came to us in a after delivery, and we could not think of operating her in the first instance. We have given concurrent chemo radiations, but she didn't respond to it. So finally we have to resort to the surgery, and finally you see the result here. The result, this is after 2 months, this is the result of this growth, and finally we lost because she was really in a bad shape. So next, this is a case of Paget's disease of vulva. You can see the lesion is there. In a Paget's disease of vulva, what you do, it can harbor some adenocarcinoma of the vulva. So it should be, margin should be quite large margin, big margins has to be taken, and it was involving here, and this is the purchase also. So we have to do wide excisions. Here the radical valve is not required, but it should be a vulvectomy, total vulvectomy with good margins. So we did it, and the margins, and it was followed up with bilateral lotus petal flap. So then what comes, what are other flaps we use? It may be advancement flap, it may be myocutaneous flap. There may be 3 most commonly used myocutaneous flaps are gracilis, tensobacillata flap, and the rectus abdominis myocutaneous flap. But there is almost always the help of, we need the help of plastic surgeons. And disadvantage is the tissue bulk is so much that it causes lots of huge bulges. So and we can do another in VY flap. So gracilis myocutaneous flap based upon medial femoral circumflex artery. The flap can rotate through 90 to 180 degrees. It has been commonly used to fill groin and vulval defects. Ram flap means this is rectus abdominis myocutaneous flap have been successfully used to fill defects in the groin and vulva, and also are commonly used for vulval vaginal reconstruction at pelvic regenerative surgery. Ram flaps may be based on either the superior or inferior epigastric vessels. This flap does not require an abdominal incision, which can be seen as disadvantageous. So there is a large lesion in the vulva, the lesion in the abdomen, so it becomes not very interesting. Tensobacillata flap is not commonly used, so I've just mentioned it, and I have got few. There is not much of video, but I have got few photographs. We made it in the video form. So the advancement flap, you can see the large lesion is there. This is a huge lesion at the mons pubis, but because it was very mobile, and we could do this advancement flap to be put, and we could have the primary closure. Gracilis myocutaneous flap, yes, this is we took the help of, this is one case we did. I have not done more than that. and it could be done. But there is, you see the bulk of the tissue, the graft tissue is there. This rectal, if it is myocardial, again we have done the one case, the region in the mons pubis, and you can see it is almost looks like mons pubis, but there is a lot of bulk. And tensor fascial fascioplasty, this is not our case. I've taken from Dr. Hecker's slide. And there is a VY flap. You can see the once the region is cut, we can take a V separate incision from the thigh and just advance it, and then put the stitch over it, and you can see this is called VY. It was a V, now it is VY flap is there. So this is the final outcome. So other methods of reconstruction after valvectomy are this is vulval reconstruction in a benign lesion of the vulva. Okay, so these are all malignant lesions. Now let us come to the benign lesion of the vulva. So what are the benign lesions we have encountered? So this is condylomata accumulata. So we have seen one or two cases of this is very huge growth in the vulva. So it came in almost with thighs apart, and we could do exercise this. And with this excision, you can see there is a large gap here over here, and that's why we have to go for a this reconstructions with the same. This is the lotus petal flap, and finally it could be the gap could be covered. You can see how nicely it will come out. Now you can see how nicely it could be covered up. And this elephantiasis vulva, it is a huge elephantiasis which came to us, and finally we did excisions, and there is a gap could be closed primarily. And so there is a perineal endometriosis. There is deep inside, so we have to cut it and going deep into it, and this is closed by this again flap. Bilateral lymphangitis vulva is there, and you can do this. This is a huge Bible. This is after the adjuvant radiotherapy in a CA cervix. So it could be done in a bilateral flap could be put in. So we have got a very rare case. It's a vulval angiomyxoma. This is angiomyxoma. What you did, this growth has gone deep into the ipsilateral fossa and gone into the up to that is you can go up to the bypass of the common ligatory. So this is a huge growth. We have to do abdominal vaginal approach, and we could do this, and stitch could be put in like this, and okay. Finally, the primary aim of the reconstructive surgery is to facilitate complete curative surgical resections of the disease with appropriate margins and preservations of organ functions. Secondary aim is to enable wound healing by primary intentions and to reduce morbidity due to scarring. So small lesions, primary closure is possible with narrowing of intraotus and eversion of vagina. Some or other reconstructive surgery required a large lesions with the adverted large gap. Out of reconstructive procedures, lotus petal flap repair is both surgeons friendly, can be easily be practiced by any surgeons little interested in vulval surgery. It is robust, cosmetic value, minimal morbidity, and we do not need any help from the practice surgeons. Thank you very much for patient listening.
Thank you, Dr. Giri. Hello.
Thank you, sir.
Thank you very much for this wonderful presentation. I thought that particularly vulval carcinoma is not very common in our country, but you have got extensive experience. Now, I think there will be many questions, but I was told that the question answer session will be at the end. So may I hand over to my teacher, Professor
I think
Chakraborty.
Professor Chakraborty has left, possibly. I can't find him.
Oh.
And so it's over to Dr. Pradeep Mitra. Pradipda,
Yes.
to conduct the question and answer session. Pradipda,
So,
if you want to give any concluding remarks on the two speakers, you can. Pradipda, can you unmute yourself first? Please unmute.
Yeah.
Yes.
Can you hear me now?
Yes.
Yes.
First, so Tulika, is there any question in the box?
Yeah, there is one question.
Tulika?
Yeah, there is one question. Dr. Orunabu Roy wants to know whether post-operative radiotherapy will affect the healing of the flaps. And his question is directed to Dr. Giri.
To Dr. Giri.
It does not affect at all. So far we have done radiotherapy in few cases, of course in node positive cases, and I didn't find any problem at all. It does not cause any problem, because this flap is dependent on the blood supply from the perineal perforating vessels, and the vessel does not get clogged up. So it does not cause any harm in posterior radiotherapy.
Okay. Oh, thank you, Dr. Giri.
So if there is no question in the chat box, any of the chairpersons, if you have got any question, you can ask.
So first of all, at the outset, I must congratulate both Shamul and Sukanto for coming up with this very important session on vaginal surgery, particularly its oncology section. I remember when I was too much enthusiastic in doing TLH and all many years back, Sukanto imbibed the idea of doing something through vagina, and since then, after getting inspiration from Sukanto, I stopped doing TLH and I'm doing all the surgeries vaginally as far as practicable. Anyway, coming down to the topic itself, in the first session, in the first part of the second session, we have just seen that what is the idea of radical vulvectomy amongst us has been totally changed. What is what I've seen is just like local excision. Even if it's restrictive to call it radical vulvectomy in its any form, it is just a local excision. The other part I have not seen over here, that is the lymphadenectomy portion. So my question to any of the speakers who are doing this vulval surgery related to vulval cancer, what about this lymphadenectomy? What are the lymph nodes are being removed? Either Giri or Dr. Bhumik, you can answer this question. And what would be the approach? Dr. Bhumik was talking about laparoscopic approach, but many of us are not that much. Yeah. So far, I remember I used to do it by 3 incisions. One vulval incision for removing the vulval growth, and the 2 inguinal incisions to remove this inguinofemoral lesions.
Yes, yeah. This is the usual thing now.
What is your point?
No, it is otherwise called triple incision technique. So that is, as the OS.
That is what I'm talking.
This is a triple incision technique. This is bilateral groin recession has to be done, and 1 incision at the vulva. So this is triple incision technique, and there's a gap between this vulval incision and inguinal incision. But now people are thinking that yes, to reduce the morbidity, people are thinking in terms of robotic lymphadenectomy, and yes, it can be done. It is being done. And finally, the result will say what is going to happen to this. But again, the same thing is being done, because the lymph node has to be removed. The lymph node is being removed. So there is no problem at all. Robotic and laparoscopy also people have started doing it.
Why I ask you this question? Because most of the viewers, they might not have the access to robotics. So
no need. There is no need.
Tell us.
Commonly done
what
is
are the lymph nodes to be removed? Just for what are the lymph nodes to be removed and how? Just in a nutshell, just tell us.
Common lymph
so
nodes,
that viewers can have the idea.
The incisions, there are variety of incisions. One is a parallel incision, one is a LGS incision. All things are there. The main purpose is to do lymph node superficial and deep inguinofemoral lymphadenectomy. When we are doing the lymphadenectomy, it should be superficial and deep. So deep nodes are usually medial to the femoral vein. One or two nodes will be there medial to femoral vein in a femoral triangle. So that can be removed without dissecting much of the femoral vessels much. So that can be removed, but superficial inguinal node has to be removed in toto. But saphenous vein should be preserved as far as possible. That's a present status.
That's my question.
So it can be, it should be preserved,
So
but it is not necessarily that it should be preserved always.
Okay. So it can be preserved. What is your practice? Do you preserve the saphenous vein or you like it?
No. If the node is involving the saphenous veins and without removing the without cutting the saphenous vein, so we have to remove the saphenous vein. We have got very videos where we have removed saphenous vein, we have not removed saphenous vein, and finally what happens? The final result is not known that whether it has an effect on lymphedema or not. But finally, as far as possible, the guideline is that we should preserve saphenous vein as far as possible, not mandatory. Dr. Bhomik, what is your opinion?
Next point.
I fully agree with that. Saphenous vein is preserved mainly to reduce the incidence of lymphedema. Lower limbs. And of course, if you can preserve the saphenous vein, as a surgeon, you feel very good. But of course, the oncological principle should not be compromised. So if there's a lymph node involving the saphenous vein, you have to sacrifice the saphenous vein. And
in that case,
usually can separate it very nicely, and that can be done.
Do you do frozen section biopsy of the clotted nodes?
That is a completely separate discussion. Yes, of course, for vulvar surgery, you can do sentinel node biopsy. But we hardly ever see cases which are suitable for them. You have to have a very small lesion, lateral lesion, because majority of our patients will actually need a total lymph node dissection. So to choose where not to do a lymph node dissection, very, very rare, once in 10 years.
That is honest.
Because we see it very late in the disease.
Okay.
Thank you, speakers. Thank you, Dr. Bhomik and Dr. Giri. And I think we should move on because we are already running late. And though we don't want the sessions to end because they have been so interesting, but still we have to move on. So thank you, Dr. Bhomik and Dr. Giri, for your excellent surgery and presentations. And thank you, chairpersons, Dr. Chakraborty, Dr. Boidanath Chakraborty, who had to leave, I think, a bit early, Dr. Pradeep Mitra and Dr. Partho Bhattacharya, for a very interactive and interesting session. And I move on to the next part, which is the vote of thanks, and which will be delivered by the Honorary Secretary of SOFSI Bengal Chapter, Dr. Shamul Sheth. Over to you, Shamulda.
Thank you very much, Tulika. Now, it's an honor and privilege to deliver vote of thanks after such a mesmerizing event, I must say, in presence of a galaxy of personalities from all over the country. I am grateful first to the High Command of SOFSI, especially my big brother laughing at me, Dr. H. Patanayak, for allowing us to organize this event, this webinar. We are in the pipeline for last 2-3 months, but ultimately we could manage. Thank you, Dada. Thank you very much. I want to thank the revered guests of today. Look at their age. They were present for so long time. Dr. Shirish Sheth, Dr. R.P. Shunawala, Professor P.C. Mohapatra, and they have given their valuable inputs and their comments are encouraging. We are feeling really encouraged after organizing the event that we can think that yes, we have achieved some success after organizing this. My sincere thanks will go to all the chairpersons for gracing the occasion and giving their valuable inputs, and the 4 brilliant speakers with demonstration of the lovely videos of malignant surgeries, which we could think of, which we could imagine, but we saw in front of my eyes. My heartfelt thank and sincere gratitude to Dr. Tulika Jha. Now, we could not show her CV, but in a nutshell, I can say she's an associate professor in the Department of Obstetrics and Gynecology, Arjikar Medical College. Currently, she is the clinical secretary of our Bengal Obstetric and Gynecological Society. But beyond this, she is a very skillful, very hardworking and dedicated worker and office bearer of the Bengal Obstetric and Gynecological Society. Thank you very much, Tulika, from the bottom of my heart.
for accepting our proposal to coordinate the events within a short notice. Thank you very much.
Thank you,
I think
Shyamala.
success
Thank
of
you.
any program will depend upon the number of people attending it. I'll have to take the feedback from the support team, how much was the audience. But whoever attended, my heartfelt thanks goes to all the persons who watched, who attended, who registered for whatever length of time they could manage. I want to express my sincere thanks and gratitude to all the people who were on the audience side. And what I can say about that person, a cool, calm, composed, with vast knowledge and the experience of everything, but still tolerating me. You know, I'm a little stubborn, tolerating my phone calls, all my idiotism, my childishness, and whatnot. I'm fortunate to have him as my boss. Yes, I'm talking of Dr. Sukanto Mishra. We could not show his CV as well. Currently, he is the professor and head of the Department of Obstetrics and Gynecology, Vivekananda Institute of Medical Science, Ramakrishna Mission Seva Pratishthan, Kolkata. He happened to be the past president of the Bengal Obstetric and Gynecological Society, and I was fortunate to have the secretary in that particular year of the same society. Thank you very much, Sukantoda. Possibly people cannot imagine how much pain you had to take for last 1 or 2 months in organizing this event. My heartfelt thanks will go to Team Lupin, especially Mr. Saurabh Joshi, Mr. Samsundar Ghosh, and Mrs. Hemsa, for all their efforts, and more importantly, tolerating my phone calls so frequently and facing my idiotic questions. I'll be failing in my duty if I fail to extend my heartfelt thank to the support team who actually helped in the technical aspects of this event, especially Mr. Darshan and whoever were present today. Thank you very much. This was, I don't know whether I failed to thank anybody. If I did so, I'm sorry. And thank you all for watching. Thank you all to be present for last 3 years. 3 hours. And I must say good night to all of you. Thank you very much. Take care and stay safe.
Thank
Regards.
you. Thank you, Team Bengal. I must say that this is one of the excellent webinar in the history of SOPSI. We started from June, and this I thought, and they carried out. I told Bengal is the center for Mitra's technique. So let's start gynec surgery in malignancy in the name of the legendary Professor Subodh Mitra. My request to all the doyens present over here to start the art of vaginal surgery and rekindle Mitra's technique. Professor Kalidas Bakshi is here. Doctor, please take over and let Chittaranjan Cancer Hospital should be the center to training and rekindling the art of Mitra's technique to the world. So let's have it. We'll again meet in the forum again. And my sincere thanks to the legendary people present over here. An excellent presentation by Dr. Sukanto Mishra and Dr. Samuel Seth. Thank you, Bengal chapter of SOPSI. Thank you very much. Thank you.
Thank you very much, sir. Thank you.
Thank you, Hala.
Thanks to all of you.
For giving
Thanks
us
to all of you.
for giving us this opportunity. Thank you. Thanks to all of you. So we can leave now.